The session will now start. I'm handing over to the CEO of SAMA, Dr. Vusi Nhlapho.
Esteemed colleagues, good afternoon to each and every one of you. I would like to specifically recognize the chairperson of the association, Dr. Mzukwa, the vice chair of the association, Dr. Edward Ngwenya, and the president of our association, Professor Chauke, sitting next to me, and not forgetting all the board members who may be present in this forum. Annually, we hold the summer conference because we believe that it is important for summer to lead in the conversations about healthcare space in this country. But more importantly, it is important for summer to unite doctors for the health of our nation. We are therefore proud to present our esteemed speakers as well as our learned facilitators. But more importantly, not forgetting our influential delegates who have sacrificed their time to engage with us today. Together with you, we hope to chart the way forward to finding better solutions to the problems that we're facing in the healthcare sector. So colleagues, summer needs you. We are clear in our minds that we cannot do this work alone and without you. We therefore are determined to work hard to unite the doctors in this country. With these few words, please join me in welcoming Dr. Mzukwa, our chairperson, to open our proceedings for the Summer Conference 2022. Dr. Mzukwa, over to you.
Thank you very much, the CEO, Dr. Nhlapho, and good afternoon and welcome to all the delegates to the Summer Conference 2022. As in previous years, this conference will be hosted virtually and face-to-face and will run today and tomorrow and close next Saturday. COVID-19 has re-engineered the way we do things. And one of the innovative ways in which SAMA dealt with the pandemic and still managed to offer valuable connections such as this was through this hybrid model that we currently use. And I'm all for it. And I believe it enhances the experience for those in attendance and for those who are joining us online. Fittingly, the theme of this year's conference is Beyond the Pandemic, Grappling with the New Normal. It's a topic many of us have had to deal with in our own situations and often without much interaction with other professionals in a similar situation. COVID-19 had a devastating impact on all of us, and many are still suffering the impact. That's precisely why this year's conference is important. It brings together practitioners, experts, and leaders in their respective fields to share experience and insights together to chart a way forward, or at least present different ways to tackle similar problems. I am really honored to be with you here today as the chairperson of the South African Medical Association and to officially open this event. Throughout the years, Summer Conference has been characterized by touching on important issues that matter to the medical profession. In this way, Summer is delivering on one of the core mandates to be the voice of the profession and further the goals and ideals of practitioners. This year is no different. Over the course of the next 3 days, the 2 weekends, you will hear from some of the most respected, knowledgeable, and influential members of our profession. Their years of experience and the lessons they've learned along the way is valuable to you. So the immense value of this session cannot be overstated or underestimated. Today's session focuses on maternal and child health post-COVID and deals with the issues such as the testing the lasting effects of the virus, and the role of district health specialist teams. An important element of this is naturally protecting the patient confidentiality, especially in relation to medical reporting. So a segment on the Privacy Act in South Africa is also included. On Sunday, the conference will focus on internal medicine and cover topics such as long COVID, palliative care, and issues relating to care for the elderly. Next Saturday, topics will deal with population and preventive health, occupational medicine, and health matters. We believe this is a comprehensive covering of the topics related to the challenges post-COVID. And I'm sure you will all benefit from the presentation our speakers make. Our inaugural speech for this year's conference will be presented by Professor R.F. Chauke, Deputy Dean at the Sefako Makgato Health Sciences University and the current sitting president of SAMA. We all know that Professor Chauke is an experienced and highly regarded cardiothoracic surgeon whose exemplary leadership in this position he has held and also served as an inspiration to all of us. We are honored, therefore, and thankful that Professor Chauke has availed himself to be with us today. With these short remarks, I would like again to welcome you all here and online, and trust that you will all live with the new understandings and fresh perspectives on your profession and the way forward post-COVID. And thank you for that. And now I will hand over to Professor Chauke, the president of SAMA.
Good afternoon, colleagues, those that are gathered in the branches and those that are virtual. To the chair of the session, the CEO of the organization, Dr. Nhlapho, the chair of the organization, Dr. Mzukwa, the vice chair, to the board members and the secretariat at large. Thank you very much, and thanks for attending this conference. Thank you, Dr. Mzukwa, for that warm welcome, and to SAMA for again convening such an important gathering of medical professionals. As we started to imagine and plan for life beyond the pandemic, let us pause here for a minute and think about all those that fought this pandemic gallantly and unfortunately did not make it. Can we take a few seconds or minute and as a moment of silence and remember all those that have passed on during this pandemic? Thank you very much. Let us all think of those that fought this pandemic so gallantly and won. Some of us are here in this midst and in this conference today. And let us think of those who fought against this pandemic, for those that made it and those that did not make it. Be it the clergy in our communities, the community at large who did their best in whatever form or manner to fight the pandemic, and most importantly, the health professionals in their different categories who were in the front line. This conference is intended to provide delegates insight into the current state of our profession and into future developments. But it's so much more than that. Before, during, and after the formal sessions, colleagues will most certainly be interacting and engaging with each other. And this, I think, is almost as important as the sessions themselves. This provides us an opportunity to share and exchange views, and is critical to our own development. I cannot therefore stress enough how important these interactions are, because they present a unique opportunity to learn from each other. Opportunities such as these are too rare these days with the pandemic, and I hope we're going back to these opportunities going forward. And I certainly encourage you all, if you are able to do so, to interact with each other as much as possible. But what did we learn from this pandemic? First, we know that this is not the first pandemic, and it certainly shall not be the last. So we better be ready. But can we really be fully ready? No. Those that are of the Abrahamic faith, you will remember that there were pandemics before. Since the beginning of time, there were pandemics like the Tower of Babel, the Noah's Ark era, the Pharaohs, and many others of such. But were the people really ready for this? Again, the answer is no. In the not so distant past, the former American President Barack Obama warned about the preparedness of the global community against the pandemic. To be precise, that was in 2014 when he stated, "We have to put in place an infrastructure, not just here at home, meaning the United States, but globally, that allows us to see it quickly, isolate it quickly, and respond so that if and when new strain of flu, like the Spanish flu, crops up 5 years from now, a decade from now, we've made an investment and we're further up along to be able to catch it." Close quote. Did that happen? No. We have seen it with the pandemics like HIV and AIDS that decimated our societies, the Ebolas of this world, and etc. The point is, we are to face more pandemics in our lifetime or beyond, and we should always endeavor to be ready for them and not to give up getting prepared as and when they should happen. Pandemics are, in quotes, rare, but they cannot be approached from a perspective that they will never happen. Instead, we need to gear up and prepare for any eventuality, and we must be ready. We were caught napping when COVID-19 hit, and especially in the beginning, we were left wanting. But as you are all aware, those limitations are symptomatic of greater health problems within our healthcare system. We cannot and must not allow these limitations to define us into the future. We must continue to agitate for change and improvement, and we must advocate for change going forward. Change for the better, for the sake of our patients, who are our primary focus. COVID-19 took so much from us, emotionally, physically, and financially. Dr. Mzukwa made reference to this earlier, but it's worth repeating that the impact of COVID-19 is far from over. Many of us look back at 2021 with some sense of trauma and anxiety, because the effects of the disease went far beyond the impact it had on our patients. When in years to come we reflect on COVID, we will be reminded of the devastating toll it exerted on our lives and on millions around us in the world, perhaps superficially only considering the number of people who succumbed to this horrible disease. But in doing so, that will be doing ourselves and our profession a disservice. Yes, there were many millions of people who died, who are still dying today because of this disease. But in contrast, there are also many successes we must learn from. In our instance, in our context, the role South African scientists and doctors played during that pandemic and are still playing now stands out. Many of us discovered, for example, that we have some of the best and brightest medical minds in the world right here in our backyard. That, for me, is one critical takeaway, and we must be proud of. When the South African epidemiologists discovered the Omicron variant, the world was awakened to the depth of experience on the work that was done on other diseases such as resistant TB and HIV here in the country. The world sadly punished us with travel advisories and bans. However, we as a country alerted the World Health Organizations because the South African medical profession is guided by ethics, and it's some of these ethics that guide us that we ponder on these coming days. The second lesson that we learned is that muno imuno ibang. Simply put in Zulu, umuntu ngumuntu ngabantu. I think that is easily understood, but I suppose we have got 12 official languages in the country. We have all depended on one another during this pandemic. Countries rallied and supported each other. The vaccines lessons taught us that even those countries that hoarded vaccines for themselves and for their people, the virus still ran ravage in those countries. And the countries that did not have the power to produce a vaccine, like the African countries in the main, were spared from the deleterious effects of the pandemic. Whether this was due to poor reporting or other factors that resulted in low reporting of the mortality numbers, whichever the case may be, the fact of the matter is that the poor countries were mainly spared. And we don't know why God has designed it that way. It was thought that once the virus lands in Africa, Africans shall be decimated. Well, here we are, the power of the collective. As a nation, we largely remained resolute in fighting the pandemic and did so presenting a united front. I'm reminded of the doctors who sacrificed their own lives to assist patients, those who spend days and weeks on the front lines, often under very trying circumstances, working in the clinics and hospitals, leaving their own families behind while heeding the call of their profession to care for others. I'm reminded of the enormous dedication and commitment of young doctors who were faced with such a serious health emergency so early in their careers, and who acted bravely to do what they were taught. I'm also reminded of the same dedication of nurses and pharmacists and porters and cleaners and all the other support staff in our health facilities who endured through these extremely trying times, again at great personal expense, to deliver health services to the poor and of our country. I want to state here publicly and categorically that without the gallant efforts of these people, we perhaps would not have managed to get through the pandemic as we did. The third lesson that we must take from this pandemic is to acknowledge that the pandemic has been a major disruptor. The economists and those who deal with finance like the word disruption. This talks radical change to the normal way of doing things. It means disturbances which interrupt the activity or process. Our lives were disrupted in a huge way. But in the process of disruption, something big and new usually emerges. We await to see what emerges from the aftermath of this pandemic. But as a country, South Africa, I feel that we also have failed to take advantage of the pandemic. At the same time, and I'm also reminded of the failings of our health system and of the problems many doctors face in simply caring for the sick. We did not have enough PPEs, not enough staff, not enough medicine, not enough beds, the list goes on. We must reflect on these problems, which created challenging environments for doctors and for health professionals at large as opportunities to improve going forward and to learn. We must because we'll be tested again, And I'm sure in the years to come, we might experience other pandemics, as we said in the beginning. We have been grappling, for example, with implementing and operationalizing NHI. I think we missed this very opportune time to implement some of the objectives and plans or elements that are contained in the NHI document. We should already have had the opportunity to use or to have a shared utilization of eye care and ICU facilities between private and private hospitals during the time of the pandemic, in a way of implementing the first stage of NHI and all the value chain that goes with the running an ICU and high care facilities. Lastly, the pandemic has taught us that we need to work together as communities, health professionals, and countries. For example, the standoff between SAMA and SAMATU leaves a sour taste for us as SAMA. However, we believe that one day these issues that bedevil us shall be resolved amicably and unite us going forward, as we firmly believe as SAMA in our motto that we should be uniting doctors for the health of our nation. This conference comes at a critical time in our fight against COVID and presents important topics that must arm us intellectually for that fight and beyond. We will, for instance, be hearing from people such as Professor Glenda Gray, who will talk on the research of COVID and how it informed our responses, and from Professor Devashish Basu, will talk on the National Communicable Diseases Strategic Plan. These are important issues, and we must listen intently. We must learn from each other, and we simply must ensure we are better prepared for the future. That's what this conference is all about. I thank you all for joining us here today. Your attendance is significantly because it signals your intent to learn and to grow, both of which are critical for medical professionals. I trust you'll benefit from these proceedings and from the presentations our colleagues make. I urge you to reflect on them intently and use this as an opportunity to improve yourselves and improve our profession for the benefit of our patients and for the benefit of ourselves as well. I thank you.
Thank you, Professor Chauke. Let me thank Dr. Mzukwa for the warm welcome and Professor Chauke for a thought-provoking presentation that they've just made. I would now like to hand over to Dr. Dango and Dr. Van der Merwe for the next session of the conference. Dr. Dango and Dr. Van der Merwe, the floor is yours.
Good afternoon, colleagues. Thank you for the opportunity to host this session. Myself and Dr. Van der Merwe will be hosting the session where we have 3 splendid speakers lined up, and then we follow that with a Q&A session. We are a bit ahead of time, so I just want to know, do we proceed or should we wait a little bit? We can proceed?
I think you can proceed, yeah.
Okay, thanks very much. So Dr. Van Merwe will introduce himself. So let me just begin by introducing myself and perhaps sharing a few slides about the organization that I'm from. So I'm just going to quickly do that. Okay, so I chair the South African Pediatric Association and I hail from the Johannesburg, Soweto region. The South African Pediatric Association is a specialty group of the South African Medical Association, and that is why we're here today to just share a quick brief as to what we do and where we're from. And I won't be long, colleagues, maybe just 2-3 minutes just to share some background, and then we'll go into an introduction from Dr. van der Merwe, and then we'll introduce our speakers. So our mission as the South African Pediatric Association is to promote and protect the health of children in South Africa. We seek to serve and unite pediatricians, parents, policymakers, and children. And we hope to achieve this through 3 key pillars, which is advocacy for the rights of children, education of parents and our peers, and facilitating collaboration with those who share this ideal. Our history, the SAPA was formed in 1970. We had periods in the early 80s where we were not as active, but since subsequently we have been active. In 2010, we hosted the International Pediatric Association Congress in Johannesburg, and this was the first to be hosted in Sub-Saharan Africa. And below is just a list of some of our past presidents. This is our current executive committee, and the committee are from members throughout the country. So we had our elections in 2021, and this is the current executive. You can find us at pediatrics.org.za. This is our website, and we welcome you to visit our website. We're also on the various social media platforms at PedsSA and SA Peds. And we welcome your interaction at this website. And just quickly to tell you that we host a pediatric conference every alternate year. So the last conference was held virtually because of COVID, and that was through the University of Pretoria. And we move from university to university every 2 years, and the next conference is going to be hosted by the University of Free State, and we're looking forward to that in September 2023. Also to mention that we have a monthly webinar where we tackle some of the difficult pediatric topics, and you can watch these webinars on the last Wednesday of every month at 5 p.m. in the afternoon, where we cover topics that are relevant to pediatric practice, including topics around COVID, obviously, as that's been affecting us in the last 2 years. And we're really looking for people to get involved and be part of the spirit of thriving and striving for kids in South Africa. And lastly, we also the official journal of this, well, SAPA is the official journal this official journal is the South African Journal of Child Health, and that is the official journal of SAPA. And if you want to go and read some of the articles through that, please do so. So that's just my quick introduction to the South African Pediatric Association. I'll hand over now to my co-facilitator, Dr. van der Merwe, to talk about the South African Society of Obstetrics and Gynecology.
Thank you, Ziad, and yeah, thank you for the organizers for inviting us to chair this session. I just want to make sure whether you can hear me.
We can hear you, thank you.
Fantastic. Colleagues, so from my side, I'm Heinz van der Merwe. I'm a gynecologist. I am working in the Tyberg Hospital in Cape Town and associated with Stellenbosch University. I'm currently the president of the South African Society of Obstetricians and Gynecologists. Unfortunately, I've not prepared such a beautiful presentation as my colleague from pediatrics. SASOG has been running for quite a number of years, a very successful society representing obstetricians and gynecologists in South Africa. I've been involved with the society probably for the last about 15 years. We've really made huge strides over the last about 4 terms under the presidency of Professor Gulab, Dr. Johannes van Waart, and Professor Greta Dreyer, from whom I have taken over. we've, under the presidency of Dr. Johannes van Baart, started the Better Ops program, which was rolled out in private healthcare in South Africa, trying to make obstetrics, especially in private practice, much safer. And I'm glad to say that the program is running very well. We've also got a very strong private practice company, Gyne Management Group, or GMG, looking after specifically of the interests of our colleagues in private practice. So SASOG has really been organized in very well functioning committees, with council members taking charge of those committees, and I think we've really thrived over the last couple of years. Our last biannual Congress was just before the start of COVID, in March of 2020, in the Drakensberg. The Congress was hosted by the WITS department of ONG, just like the pediatricians. Every Congress is hosted by one of the academic departments in our country. And I'm glad to say that our next Congress will be at the end of this year, end of November, in Cape Town at the CTICC. The Congress will be hosted by the ONG department of the University of Cape Town, and we are glad to say that this will be an in-person Congress. I think we really are looking forward to some social contact and meeting our colleagues again. So if there are any one of you on the meeting this afternoon that are interested in attending the SASOG Congress, you can just go onto our website and you will find information, and you will be able to register. In addition to that, we also have a regular CPD program, which is over the last or since COVID has been happening virtually, like many things that happened. And we are glad to say that our CPD program, which will start within the next 3 weeks, will take the form of hybrid meetings. So the meetings will be held in the big centers in South Africa or in our various regions. But because of the hybrid model, those from other parts of the country who is not located close to where the meeting is hosted will be able to attend that. So that, in short, a few words from SASOG. And so without further ado, I'm going to introduce the first speaker for this afternoon. The first speaker is Dr. Tony Berman, whom I think is very well known to all of you. Dr. Berman's presentation will be on the POPIA Act, and I think we are all very aware, since the POPIA Act came into act over the last year or two, we've had to really deal with that and change the way that that we practiced, and specifically how we secure information under our control and how we share information. So Dr. Berman got his undergraduate degree from UCT, where he also got did a diploma in occupational health. He's a foundation fellow of the Faculty of Forensic and Legal Medicine of the UK. He's also accredited mediator He is a business and medical legal consultant of MPS currently, and he has been in that role for quite some time. He's the CEO of Cape Primary Care, QualiCare IPA in the Western Cape. And that is quite a big IPA with 600 family practitioners, and hence also a board member of the IPA Foundation of South Africa. So Dr. Berman, also in his social and personal life, is a keen cycler and walker, and a huge fan of music, being a recreational pianist and guitarist. So Dr. Berman, without further ado, over to you. We're really looking forward to your presentation.
Development. We understand that your schedules are busy, so to help, we've developed many flexible ways for you to stay informed and learn, such as our range of online courses that you can start, stop, and pick up wherever, whenever. With our webinars, you can participate live or on catch-up at a time that suits you. And our virtual and face-to-face workshops provide an opportunity for deep learning and skills development, along with valuable discussion with colleagues on essential medical issues. To explore all of the training options available to you, simply visit our online learning hub. Reduce your risk and protect your career with doctor-led professional development from Medical Protection.
It's indeed a privilege and a pleasure to be asked to address the SAMA conference on specific aspects of the POPIA, POPIA or POPI Act. People have said to me, Tony Berman, why are you again going to be talking about the POPI Act? Truth be told, when we first started the series of lectures, the POPI Act had just come in. There were a lot of flat spots in the execution of many of the clauses in the POPI Act. The information regulator had run into considerable difficulties in that her website wasn't able to. Various deadlines came and went, but I'm happy to be able to explain now that POPI is in full swing, and the regulator has indicated that she will shortly be sending inspectors out into the country to check on the compliance with various aspects of the POPI Act. So over the next two talks, one today and one tomorrow, I'll take you through much of the basics as well as some of the latest information on the POPI Act, so that at the end of it all, both you and I will be confident that each other is 100% compliance with the POPI Act. I do hope that you enjoy the talk. During this course, and certainly by the end, we will have gone through important definitions, who may process personal information, items like consent, staff training, security, operators, who they are and what they can do, the registration with the information regulator, things which could go wrong like data breaches, and then the alignment of your POPIA and your PIA manuals. Now, definitions are rather mundane, but there are four important definitions which will carry you through this course. The first being the data subject. Data subject refers to the patients and can also refer to your employees, both of whom you are collecting data upon. Then there's the responsible party. The responsible party in POPIA is you, and as the chief executive, in inverted commas, of your business, you are the responsible party responsible directly to the information regulator. You also will be interacting with third parties who process personal information in terms of a contract with you, and they are referred to as operators. Now, they may or may not come under your direct authority, but most of the time they don't come under your direct authority, and therefore they are seen as operators and not as staff. And then finally, consent. And consent is fairly well known amongst the medical fraternity, but importantly there are words like voluntary, specific and informed expressions of will. So as the information officer, we have certain duties which are important for us to undertake. We need to develop various internal systems for dealing with various data requests. 2, we need to put together an impact assessment as we look into our security measures as to how we need to change, where our weak spots might be, and what to do if there is a data breach. We need to develop a full POPIA plan within a compliance framework and have that filed in case we have an inspection. You need to run regular staff training sessions. So altogether, it's important that as responsible individuals and as information officers, we approach this in a constructive way. So personal information is a term which is bandied about quite a lot. But I'd like to go over certain aspects of personal information and just show you how exactly widespread it really is, because it's any information relating to any identifiable living natural person or existing juristic persons. And the elements included are things like, on a personal note, your race, your gender, your sex, whether you're pregnant or not, whether you're married or not, your sexual orientation, your age, your physical or mental health, any appointments that you might have with doctors, and the diaries that reflect these appointments. And that's particularly important and one that is often forgotten, because doctors' diaries are a source of a tremendous amount of personal information, which is of huge value when it enters the dark web. Details on whether you are well, whether you have a disability, your religious beliefs, your language, details of your culture, details of your conscience, your educational status, and specifically for doctors, your medical conditions, but also your financial status, and then the employment history of the person. Very important here when you are about to give a reference on a staff member or a patient. You need to get full permission to do that. Also, any information of a criminal nature relating to the patient or to the staff member is personal information. And it goes even more deeply. Any symbol, your email address, your physical address, even your phone number, and any other identifying number. These are all items of personal information. And there are more. Further categories of personal information include personal opinions, or any views or preferences of the person, as well any correspondence which has been sent by that person or even to that person, or correspondence which could reveal the contents of any original correspondence. That's all classified as personal information. Any views or opinions of any individual about a person or a patient is personal information, and biometric information of that individual, measurements, etc., fingerprints, retinal scans, etc., that's all personal information. And then finally, if the name of the person appears with any other personal information relating to that person, or if disclosure of the name itself reveals information about the person, that is classified as personal information. I think it's important, I'll leave these on the screen for a couple of moments longer for you to just digest this, because much of our referral falls into personal information. Now the good news is that the medical profession is exempted from using personal information, which I will explain to you in the next couple of slides. But nevertheless, we are still handling personal information. So there's a general prohibition from processing personal information, information dealing with topics like your health, like your sex life, like your biometrics, all the stuff that I've mentioned in the previous slides. Religious, philosophical beliefs, political persuasions, trade union membership, race, etc. Normally, people may not process this information. There is, however, a very clear exemption for the medical profession. There's a specific exception in POPIA, it's in section 32, which exempts the medical and dental and other healthcare professionals, as well as the other organizations which I've placed onto the screen, including medical schemes and their administrators, and allows them to collect and process information, providing that, and always providing that this information is necessary for either the treatment or the care of the patient, or for the efficient administration of that institution or professional practice concerned. The patient has got to give consent prior to giving this information, and the consent includes understanding what kind of processing is going to be performed on the data that they have volunteered. I think, therefore, they were all agreed that doctors and dentists and other registered healthcare professionals and their staff can collect and process medical information, again I say, provided that there is a written consent from the patient. Now, I want to point out that the HPCSA has got a specific booklet on maintaining client confidentiality, and I would urge you all to go and read that booklet so that you are within the bounds of not only POPIA, but also of the HPCSA's confidentiality ethics booklet. Remember too that your staff, as we said, are entitled to process and collect information. However, they have got to sign not only a confidentiality, but they've also got to sign a non-disclosure agreement with your practice that they will not leak any of this information, either during their tenure in your practice or when they move on. We often have doctors and funders at opposing ends of the spectrum as far as whether or not the medical schemes or the administrators can access various aspects of medical information. And here section 32 again makes it quite clear that these modalities can collect and process the information pertaining to patients, providing that the data subject, in other words the patient, has not objected to the processing, that the performance of any medical scheme or insurance would be negatively affected were they not to be able to access this information to effect the service that they're offering the client, and also for the enforcement of any of their contractual rights or obligations. Throughout the talk, I'm going to be projecting various summary documents which we will recap in part 2 of this discussion on POPIA. This is the first of those examples, and this is a typical specific and adequate expressed consent to gather personal medical data. The beginning part is pretty standard. The patient is consenting to the process of collecting personal information in terms of POPI, and that permission is given to the doctor and the staff and any third-party operators which the doctor has a contractual relationship with. The purpose of gathering this information is fivefold. It's firstly to treat and manage the patient in terms of the doctor-patient relationship. It's to administer the the contractual relationship between doctor and patient, and also to communicate with other persons as it relates to the patient's treatment and management. It also is to communicate with third parties who are indemnifying the patient for the cost of treatment and management, in other words, sending the accounts to the medical aid. And finally, it allows the doctor to collect monies owing from the patient for medical services rendered which have not yet been paid. So as there's specific permission in section 52, there is a specific warning in section 57 that special caution needs to be taken if you're processing any information for a process different to that for which you originally obtained the consent. Furthermore, if you are gathering the following kinds of information, and we list unlawful behavior, in other words, criminal actions, credit reporting and blacklisting, sensitive information about children, and on closed references, then you might have to get special permission to gather and process that information, and you are earnestly advised not to dabble in that kind of information without chatting to your indemnifiers, in this case MPS. On my initial set of introductory slides, I mentioned various modalities that we would make sure that you were familiar with, and the next one is confidentiality, which is really the basic tenet of our profession. There's nothing much new here, except that we need to refocus on confidentiality, and specifically whether we are protecting the what, the where, the who, and the by whom. So what information are we gathering in our practices? How are we storing it? Who has access to the information? And who can process that information? If you've done 1 through 4 and you've got express consent, you've done well on confidentiality. Well, we're halfway through this particular presentation of the catch-up for POPIA, old and new, the information which has changed, the information that has stayed the same. And I'm going to spend a couple of minutes now talking about security of the information that you have taken. And the word reasonable and reasonability comes up repeatedly in the particular act, as it indicates you must secure the integrity and the confidentiality of your patient's personal information by taking appropriate reasonable measures. To do what? To make sure that there's no loss, no damage, no unauthorized destruction of PI, and no unlawful access or processing of PI. In looking at security measures and reasonable security measures, we take an occupational health approach by indicating that you need to do a risk analysis of your practice to identify all foreseeable, reasonably foreseeable, internal and external risks to PI, that is, in your practice, in your position and under your control. You need to establish and maintain appropriate safeguards against those risks, and then make quite sure that those safeguards are effectively implemented and regularly verified. And then finally, update those safeguards in response to any new risks or newly perceived deficiencies on a regular basis. We recommend that you do this annually, so that your annual security risk assessment is kept on file, just in case an inspector pops in from POPIA and wants to have a look and see what you have done to mitigate your risks. The Health Professions Council of South Africa has produced a series of booklets, and I recommend that you go through booklets 1 and 2, as well as booklet 5 on patient confidentiality and 9 on patient records, specifically remembering that electronic records should be password protected. That also sits inside patient records. Turning to security of your data, the Act repeatedly, as I mentioned earlier on, stresses reasonability. So you need to just adopt a common sense, reasonably based approach. So not every practice is going to be the same as every other practice, and you do what is right for your practice within your budget. But some of these simple things which you can do is make sure that you are up to date with your antivirus. Make sure that your premises are fully secured at night, that they're alarmed, that your records themselves are under separate lock and key in a locked file or filing cabinet, or if they are in a computer, if they are correctly password protected, and that your computers are locked up in a strong filing cabinet. Remember, keep on doing security assessments. We've said at least once a year, but probably at the end of every day, you can cast your eye around and just look to see if there's anything that you should brush up on from a security point of view. We're still amazed and sometimes rather disappointed when we find out that colleagues have actually left patients' folders lying around on tables or in a pile on the doctor's desk, and then he leaves the room and leaves a patient sitting in the room who can then quite brazenly page through not only their files but other individuals' files as well. So please never leave patients' files lying around. Security needs to be top of mind, not only with you but also with your staff. So I mentioned earlier on that you need to sign confidentiality agreements with your staff. Please don't forget this. Make sure that anyone that is handling health data not only signs a confidentiality, but also in their letter of appointment understands that disciplinary measures could be taken against them for non-compliance and breaches in security. Please make sure that induction sessions in security training and POPIA are held with all new employees, and refresher courses at least once a year. Not only do you have to do the courses with them, but you've got to document and retain proof that you've run those courses, that each individual member of staff has got to sign attendance, that they have been to those courses in case you have a data loss or in case you have an inspection. And then very, very importantly, be extremely cautious when you send information to just anyone. Certain medical aids might ask you for data which they may or may not be entitled to have. If you are in any doubt, please contact your indemnity organization, in this case, Medical Protection Society. In order to do your job as a doctor, you almost certainly will have to contract with person or persons outside of your practice. These are termed operators. They don't come under your direct control, but they perform functions which allow them access to personal patient data. For example, companies who store your files, claims administrators, even your auditors are privy to a lot of patient information. Remember too that you are the responsible party, so that if any breach of confidentiality happens at the operator level, you are equally responsible for that breach. And you need to contract very clearly with that operator to make sure that you mitigate your own risk. And we'll go through those contracts in a moment. I know WhatsApp is on the tip of your thumbs and your tongues. And currently, it's being investigated by the information regulator with regard to its security certificates and storage. But quite recently, the Health Professions Council, as far as telemedicine and telehealth is concerned, have actually indicated that WhatsApp may not be used when communicating with patients and transmitting private confidential information to them. Operating companies and operators may only process information with your prior knowledge and your written consent. They also need to sign a contract with you, which we will go over with you in the next slide or two. But in it, they undertake to treat all personal information which comes to their knowledge as totally confidential, and that they will not disclose it unless they are required to do so either by law or in the course of the proper performance of their duties. So I'm going to present to you a checklist to be used when you contract with outside operators. So make sure A, they agree to undertake to comply with POPIA. B, or 2, to undertake to treat all personal information as totally confidential. Thirdly, to undertake to maintain responsible security measures of their own as required in Section 19 of the POPIA Act. Fourth, they undertake not to process any PI without your knowledge or without your authorization. Very importantly is number 5, where they accept the obligation to notify you as soon as is reasonably possible of even the suspicion of a data breach, and then to indemnify you, and I've used red ink here, to indemnify you against claims, fines, and penalties which might flow from a data breach where they themselves have not implemented Section 19 measures. Hello?
Hi, colleagues. I assume that was the end of Dr. Tony Berman's pre-recorded presentation. Dr. Berman, can you maybe just confirm that?
Yes, sure. Now okay. that is the end of part 1. And what we thought that we would now do was just take some questions. I see that we are almost hard up against time if you are watching time carefully, but I'm going to hand over to the chair. I'm ready to chat with pleasure.
Yeah. Maybe I think the way that we understood it is that we have a question and answer session at the end of the session. So just to remind the delegates who attend the meeting to please post your questions in the Q&A box. There aren't any questions yet. So here's one question, and we will deal with that once the other speakers have concluded their talks, if that's fine with everyone. So colleagues, in the meantime, please send in your questions, and we will deal with them at the end of the session. There's specifically 30 minutes at the end of the session specifically for questions and answers, and we will then have all of the speakers to attend to your questions. So that then leaves me to introduce Dr. L Pistorius. Lo is a qualified obstetrician and gynecologist. He, after completing his undergraduate studies at the University of Pretoria, did his postgraduate studies at Stellenbosch University, then trained as a maternal fetal specialist, after which he went to the Netherlands, where at the University of Utrecht he completed his PhD in fetal brain imaging. Lo thereafter returned to South Africa, and he's currently in private practice in Cape Town. Lo is really a well-known fetal specialist, not only in Cape Town and South Africa, but really internationally. Lo currently is the president of the South African Society of Ultrasound in Obstetrics and Gynecology. Lo, I can really carry on a long time in introducing you, but I think that is enough. Louw is really an expert, so I look forward to his talk on viruses in pregnancy. Thank you, Louw. Over to you.
Thank you for that very kind introduction. We can go with my talk from here. If there are problems with the internet, then we could definitely just swap to the pre-recorded talk. And I'm sure that you are wondering what the effect was of what the effect was of COVID during pregnancy, and also how are we now that we are slowly exiting the whole COVID pandemic, what are the effects that we are still feeling on our own in our own practices and also feeling in our own bodies. But I think also good just to talk a bit about what other viruses there are still around that are also of importance in pregnancy. So we'll talk of the quite well-known viruses that affect pregnancy: COVID-19, influenza, and HIV, but then also have a look at some other congenital infections. And of course, good to know that although we've all been affected by COVID as a virus, there are many non-viral infections that can also influence pregnancy. So locally, we are fortunate that very early on in the epidemic, there is a study that appeared, South African arm of an international cohort study of the effect of COVID in pregnancy. And this was a population-based cohort of 36 hospitals across 6 provinces in South Africa. In interpreting the results, good to be aware that 35 out of 36 of these hospitals were state hospitals. Completed COVID clinical record forms were received for over 670 women, and those were patients admitted between middle of April and end of November 2020. And if you look back on where we were in the pandemic, this then places us in the study in that first wave of COVID, when, if you remember, we didn't really know what was going to happen. Lots of preparations were taken, but we didn't quite know clinically how should we be treating these patients. And also good to know that that was in a time when there was still a relatively high mortality of COVID, and not as in these last phases when the mortality of the infection has largely dwindled away. So back to the study of the 670 odd women that were enrolled in the study, about a third were hospitalized. Half of those again needed critical care, and 40 pregnant moms died in this cohort. On the neonatal side, there was also more morbidity. A third of the babies delivered pretermly. 63% were delivered by cesarean section. And again, good to remember that this is a group of patients in a state hospital. In private practice, of course, a 63% cesarean section rate would be pretty average. There's also 4.7% risk of stillbirth, 2.3% of the cohort had a neonatal demise. So altogether, 7% of the infants didn't make it. No vertical transmission was seen though. So from this and other studies, and of course there are already many meta-analyses around, it's become obvious that the pregnant women that contract COVID-19 were at increased risk of severe disease and also at increased risk of obstetrical complications. There wasn't really an increased risk seen of vertical transmission, of miscarriage, or of congenital anomalies, in contrast to other viruses such as influenza. And also good to note that vaccination reduced the risk of both of contracting COVID-19 and the risk of severe disease. And again, thinking back about our management during the different waves of COVID, initially vaccination wasn't done during pregnancy at all, then only in the second half of pregnancy. And it has been proven that vaccination is actually safe in any of the trimesters. Acute care for the mom with COVID was primarily the maternal care, and that didn't differ so much from other patients with COVID with extra morbidity, with hospitalization if needed. Main aim of the treatment maintaining the oxygen levels, and of course in the pregnant patients preventing venous thrombosis is also very important. On the obstetrical side, if the pregnant mom was admitted after viability, corticosteroids should be given for fetal lung maturity. Fetal monitoring would, of course, depend on the maternal condition, because if the mom's condition was deemed so bad that she would not be able to withstand a cesarean section, then there's not much sense in fetal monitoring. And on the obstetrical side, as is often the case, most of what we could do was spent around figuring out the best timing of delivery. It has also become clear that in the care of pregnant women who've survived COVID, who contracted COVID and became well again, is that there was still an increased risk of fetal growth restriction, preterm labor, and stillbirth. And looking at the percentage of these pregnancies that run into trouble, it's no surprise as there's signs both of maternal and fetal vascular underperfusion, often mild inflammatory changes, and then of course, if you let the pathologist loose with an electron microscope, you could see the COVID particles in the syncytial trophoblast in the placenta as well. Much has been written about the psychological aspects of COVID-19 in pregnancy. And one picture I have in mind is a colleague of mine that put a chair in the passageway so that the fathers that usually accompanied the moms together to the obstetrical visits would actually be sitting outside in the passageway. And we have heard much about the fact that women had become more isolated. We've also seen reports of an increase in gender-based violence due to the forced cohabitation, especially during the strict lockdown period. On the other hand, there have been positive psychological aspects as well. Many moms found that they could actually be at home and rest and relax and take more time to spend their time with their pregnancy and then with their infants afterwards. The true repercussions, I believe, is something that we will only see in a while as we see the waves in the pond slowly dying out. Of course, COVID hasn't been the first big respiratory pandemic. And if we look at the big influenza epidemics of 1918, 1958, and 2010, the cartoon is here taken from a local newspaper depicting the death caused by the so-called Spanish flu in 1918. In these big influenza epidemics, it's also been clear that the pregnant women were more seriously ill, more at risk of death, and the extra high if there are comorbidities, especially other respiratory problems, cardiac problems, tuberculosis. Fetal effects, we also saw the increased risk of pregnancy loss, preterm birth, and stillbirth, but also an increase in congenital anomalies, especially if there was severe hypothermia in the first trimester. Treatment although in acute phase, influenza can obviously be treated symptomatically and by antivirals. The best treatment is prevention, and that is by ensuring vaccination of women in reproductive age. And if someone is already pregnant, then that's also a good time to do influenza vaccination. In terms of HIV and pregnancy, we've also come a long way in the past few decades, and it's really been reassuring when looking at the reports of HIV in this cohort that you talked about, looking at the COVID viral infection in April to November of 2020, that of the 220 patients that were HIV positive in this group, 94% were on ARVs and 72% were virally suppressed. Again, it's good to remember that this was a hospital-based study, and things might be very different in small rural clinics, but definitely very reassuring to see the distance we've come in terms of caring for HIV positive pregnant women. On the other hand, we know that HIV in adolescents still is a huge problem, that there are many new infections every week in the adolescent group. And we also know that teenage pregnancy is a huge problem in Southern Africa, so that there is still lots of work to be done. And now that we're slowly picking up ourselves from the COVID pandemic, it's good to remember that this pandemic has been with us for a long time and is still going to be with us for a long time. Hopefully, lots of this energy that's been put into developing vaccines for COVID can also be applied to make sure that we can get some decent vaccines against HIV. In terms of the other congenital infections, I think it's good to think, which other congenital infections are really the most common and the most dangerous? How can we prevent them? How can we diagnose them? How can we treat them? And in terms of vertical transmission, it being transmission of a virus from the pregnant mom to her unborn child, there are several steps needed for that. The first is that the mom herself is infected. Secondly, that the virus manages to cross the placental barrier to the fetus and then, in fact, infect the fetus. And then the last thing we the most worry is that the infected fetus then becomes affected by the virus. And of course, if that sequence is broken somewhere along the line, it can be that the fetus escapes unscathed despite maternal viral or other infections. So answering the first question, CMV or cytomegalovirus is still the most common virus transmitted from the pregnant woman to her unborn child. This is from the National CMV Foundation in the United States. And the statistics are that 1 in 3 of pregnant women who get CMV will pass the virus to their unborn child, leading to 1 in 150 children actually being born with congenital CMV. And that's much more than all the combined metabolic and endocrine disorders in the newborn screening panel, which I think don't even think we get around to. It's much more common than Down syndrome, for example, which we as obstetricians spend a lot of our time screening for. The question is, of course, what is it like here locally in South Africa? And a study from the Eastern Cape has shown us that the picture here is in fact actually a lot worse. They did swabs of neonates, subsequent neonates, and just to get some idea of the prevalence of CMV, and found that actually 6% of neonates in their institutions were actually born with congenital CMV. And that means it's not 1 in 150 as in the United States, but nearly 10 times that amount. So this is really another huge pandemic, a huge burden from virus infections in pregnancy that our population is facing and having to carry. Often we see CMV infection, or actually the fingerprint of CMV infection during pregnancy by a very specific ultrasound or MRI appearance. Serology doesn't help us that much because it can be very misleading, and our way of diagnosing it when we see some of these very specific ultrasound or MRI findings would be by doing an amniocentesis and doing a PCR for the CMV, or doing a chorecentesis, doing a fetal blood sampling and detecting anti-CMV IgM in the fetal blood. And of course, IgG is an antibody that crosses the placenta readily, and that's a reason why babies are much better able to ward off infections than ostrich chicks. But if we do find IgM in the fetal blood, then we know that the fetus has been infected and its immune system is actually making antibodies against it. Management would be if it's detected asymptomatically. In other words, we know a mom is seroconverted, but we don't see any fetal symptoms on ultrasound or MRI. That fetus has to be followed up because the affliction can still present much later on. If it remains asymptomatic prenatally, then neonatal evaluation is important, and there might be a role for antiviral therapy. Of course, infants that really need long-term follow-up, and which I'm afraid is often lacking in the very segment of the population at highest risk of contracting CMV. If really severely affected fetuses are found prenatally, then a pregnancy termination would unfortunately be the one option to consider. And in the mildly affected fetus with maybe mild ventriculomegaly or maybe slight echogenicity in the brain around the ventricles, there is the question whether intravenous immunoglobulin or antiviral therapy might have a place. There's no vaccine, so in terms of prevention, I would think the most practical way is probably to tell the adolescent girls to be taking care of their nephews and nieces, especially when they have a flu, that they can contract CMV before falling pregnant themselves. The general hygiene, which is actively promoted during pregnancy, unfortunately, is not very effective. So CMV, definitely the most common, rubella probably the most dangerous. We know that where a pregnant woman has contracted rubella in the first trimester, 90% of the babies are likely to be born with congenital rubella syndrome, with a variety of serious problems with cardiac problems, deafness, blindness, neurodevelopmental abnormalities. And there, fortunately, we have an excellent vaccination, and it's been reasonably effective by not only blanket vaccination of all adolescent girls, but also checking the rubella antibody levels in pregnant women, because the pregnancy at most risk for vertical transmission of infections is not the first pregnancy, but subsequent pregnancies. And in the first pregnancy, it still is relatively easy for the mom to keep herself away from possibly infected kids. But from the second pregnancy on, the kid usually brings a variety of infections from the creche or the school or the children's party. Varicella and congenital varicella syndrome, much more on the background, although congenital varicella syndrome can be as devastating with severe microcephaly, hydrocephalus, etc. It's much less commonly vertically transmitted. And the biggest risk is actually of clinical neonatal varicella infection if the mom develops an infection after 36 weeks of pregnancy. Also an infection with very definite maternal risk. And once the maternal risk has been sorted out during the initial infection, then the fetus needs to be followed up with serial ultrasound examinations. And with varicella, because there's very definitely a maternal risk, then antiviral therapy is also a very definite consideration. Parvovirus B19, which is not an infection that is outside of pregnancy that much of an issue, although it can give symptoms like fever, headache, the usual viral type of infections with very specific rashes and body aches and joint pains as well. In the fetus, it can be devastating, as in this fetus, these you see here in these ultrasound images with a large floppy heart with pericardial and pleural effusions and ascites, because this fetus has developed anemia from because of a vertically transmitted parvovirus B19 infection. And every couple of years, maybe every 5 to 7 years or so, we have a minor epidemic of parvovirus B19. We haven't had one for a while, so I think that is another infection that's lurking in the wings now that COVID-19 is vacating the center stage. And if parvovirus B19 has been confirmed in a pregnant mom, then serial ultrasound monitoring is done, measuring the middle cerebral artery. And we do that because we know the fetus can become anemic from parvovirus B19. If the fetus becomes anemic, same as with any other patient that becomes anemic, there's a hyperdynamic flow state that develops. We can very easily measure the flow rate in the middle cerebral arteries. And if that rises, then we know the fetus is very possibly anemic. And if there is evidence of either anemia, a hyperdynamic circulation, or fetal hydrops, fetal blood sampling can be done. We can measure the fetal hemoglobin count and then give a transfusion if needed. Usually just 1 or 2 transfusions is needed, and with a very good prognosis, if we catch a fetus before it's hydropic, it is a more than 90% survival rate. And it's really in the hydropic fetuses where there's a lower survival rate and also an up to 10% risk of neurodevelopmental anomaly, which might be a viral effect, or might be indirectly from hypoxemia because of a severe anemia. About Zika virus, we heard a lot a couple of years ago, and we know transmitted by mosquitoes, mainly in Central and South America, can also be transmitted from vertically from mother to fetus with really devastating microcephaly. And the virus can also be transmitted sexually. So our poor Sevens team got a message that they have to abstain from intercourse for 6 months after returning from South America. Unfortunately, the virus is also blocked by barrier contraception, so we managed to get them out of their distress in that regard. Zika, of course, also a virus that we see specific epidemic waves, and the next epidemic wave also probably waiting to happen within the next couple of years. Of course, many other infections are really, really important in pregnancy. The brief was really talk about viruses, so let's not forget the non-viruses like syphilis, toxoplasma, malaria, hepatitis. Well, hepatitis is of course a virus, but not on our main list this afternoon. And listeria, and just remember that there are many infections that can affect the unborn fetus. And I've heard we'll wait for the questions till question time, and you can think about your questions while looking at this lovely quilt made by a group of moms that were locked in during the lockdown phase. Thank you.
Thank you very much, Dr. Pistorius, for that really insightful talk. As you said, we will be waiting after the next speaker to take these questions. So thanks very much for your talk, and I hope that you will just keep an eye on the Q&A where these questions will be coming through. So colleagues, please, if you can post your questions in the Q&A, There have been some questions already coming through for the first talk, and if you could continue putting through your questions. We have one more speaker for this session, and then we'll have a 30-minute Q&A session with all three speakers. So without further ado, let me then welcome our next speaker. Our next speaker is Professor Feucht, who is a pediatrician working in the Tshwane District Clinical Specialist Team in Gauteng. She also has a joint appointment with the Department of Pediatrics at the University of Pretoria, and she's the director of the Research Center for Maternal, Fetal, Newborn, and Child Health Strategies of the University of Pretoria. And today we're fortunate because she's going to talk to us about the role of the district clinical specialist teams. So over to you, Uta, for the talk.
Good day to you all, and thank you for the invitation to join you today. So my name is Uta Feucht, and I'm a pediatrician from Pretoria. I was asked to talk about the role of the DCSTs in the South African health system. So to start off with a disclaimer, I am the current pediatrician in the Tshwane DCST, and I will explain to you exactly what that means. And I have been in this post for the last 10 years already. So in terms of the background of the establishment of the DCST, there was an attempt to meet the Millennium Development Goals for mothers and children about 10 years ago, and this was, there were components to this. This included the appointment of 3 ministerial advisory committees on reducing the mortality in key groups, and these key groups being maternal deaths, perinatal deaths, and then also childhood deaths. There was an appointment of a ministerial task team to advise on strengthening clinical government at district level, and they had tabled their report in 2011. And then subsequently in 2012, the DCSTs were appointed. So what and or who are these DCSTs? The abbreviation stands for District Clinical Specialist Teams. It is a team of healthcare professionals with a focus on maternal and child health. They were to be appointed in all 52 health districts in South Africa, and these teams conceptually are multidisciplinary, and they consist of doctors and nurses. So the full team would consist of a family physician, an obstetrician gynecologist, a pediatrician, an anaesthetist, a primary healthcare nurse, an advanced midwife, and a pediatric nurse. So various specialist clinicians who then work together towards the goal of improving maternal and childhood health within the district health system. The initial job advert came out in end of 2011, and these are the key performance areas that were then defined and which is still true today. So the key performance areas are to support service delivery, to provide education and training, to support health systems and logistics, to monitor and evaluate services, to collaborate, communicate and report, and to support organizational activities within the district. So you can see from this that this is a very broad job description, which is at the same time the good and the bad of these positions, because it is really difficult to measure the impact of the DCSTs, because they are really there to strengthen the health system. But you can also see from all these components that are listed here that these are absolutely crucial bits within the health system that we need to get right. We cannot provide quality health services without monitoring and evaluation, without teamwork, without all of these components that are part of the DCST's job description. So coming back to the time when the DCSTs were actually envisaged, so that was the time of the Millennium Development Goals. You would know that we are now on the Sustainable Development Goals. But let's just go back a few years. You can see here on this graph that when in 1990 the Millennium Development Goals kicked off, as a country our under 5 mortality rate was 61 per 1,000 live births. So all the countries who had signed up for the MDG goals had were given the target for a 2/3 reduction, for instance, in the under 5 mortality rate. This means South Africa had got a target of 20 per 1,000. So one would think that if one gets a big target like this, it's already a big ask, 2/3 reduction in childhood mortality. It would be all systems go to actually start decreasing this childhood mortality. You can see from our graph, though, that South Africa first actually went upwards instead of downwards. And there were a few countries in the world, many of them are our neighbors, who actually had the same pattern. The majority of countries just had a sustained reduction. Not everybody then actually met their goal. But this pattern was really a pattern that was found in Southern Africa, and it was really driven by the HIV epidemic that then coincided with this period of the MDG goals. So if we compare it with South Africa at the same time with the Sub-Saharan Africa under 5 mortality rate, you can see that Sub-Saharan Africa came from a much higher baseline mortality rate than we did, but overall the continent didn't have this upward bump that South Africa had. And again, it is really because of the HIV epidemic that hit us so hard in those years. Unfortunately, also know that South Africa has a lot of children who still live in poverty. And we actually have this dual epidemic of malnutrition and then also over and unhealthy nutrition. And this is something that we as South Africans really need to put very high onto our to-do list. We cannot keep on having children who have malnutrition living amongst us. So in order for us to take note about the under 5 mortality, you can see on this world map, which is weighted according to under 5 deaths, that Africa and India in the world are really the overrepresented in terms of the under 5 deaths. So this is, we have our work cut out for us, and this is where the DCST work then also fits in. How do we reduce maternal and childhood mortality? That is really the question that South Africa has asked itself and is still in the process of. So just to remind us about the HIV pandemic that engulfed our country a few years ago. So one would think, if we think about it today, we might think, okay, but HIV's been around forever. That's sometimes how it feels. But actually in 1990, our HIV prevalence was less than 1%. And it was really this pandemic that engulfed the southern tip of Africa, which really had a major impact on our maternal and child mortality. And this was our demographic curve in the year 2000. You can see the bell-shaped curve of in terms of males and females there. And this is the graph showing all the red blocks are all the people that this country lost because of the HIV epidemic. So this epidemic has really had a major impact on our demography in the country, and we are still feeling that today. And the really big impact has been because it was an infection that was very prevalent amongst young people, people of reproductive age, and therefore then also having this severe secondary knock-on effect on transmission to children and outcomes in children. What it did to our country is that it really dropped our life expectancy. And you can see it's been because of the activism and because of our big ART program that then started off later on that we were able to reverse this trend and really increase our life expectancy in our country again. We have come a very long way in terms of actually actioning our HIV program. This is, for instance, the PMTCT guideline and an excerpt from the IMCI guideline, which is IMCI is the Integrated Management of Childhood Illnesses. These programs, these big health programs, our HIV and PMTCT programs, have become part of what's happening at primary health care. We have nurse-driven antiretroviral initiation and monitoring to a very large extent. And this is how, because we have over 8 million people in this country, this is how we have chosen as a country to actually implement our HIV program. And this has really been able to open the door for us to expand the treatment access. But obviously this comes with a lot of hard work happening at health facilities in our country. And this needs to be the guidelines need to be up to date, the training and monitoring needs to be in place so that we can really provide high quality services. So coming back to our childhood mortality, I showed you the initial SDG targets there. So South Africa initially, as I had said, had actually unfortunately first increased in terms of the child mortality, but subsequently has the childhood mortality has come down. And a very large degree, this is at the same time span as the ART and PMTCT interventions have been rolled out at scale. There have also been other interventions, for instance, added immunizations to our EPI schedule that haven't had an impact on that. The other thing to note on this graph is that lowest line, the blue line, and those are the neonatal deaths. So you can see on this that while for under 5 mortality, the infant deaths, we've been able to reduce them significantly. The neonatal deaths are still nagging behind. They have been naggingly constant over the years. Our SDG target for child mortality is we need to get to less than 25 per 1,000, and we will need to really get working if we want to reach this target by the year 2030. Because as you can imagine, it's becoming harder and harder actually now to have these mortality gains. And the other thing to remember is that while HIV is not the main driver of childhood mortality anymore, the HIV epidemic amongst women in South Africa, the prevalence is still around 30%. This means that we are in this for the long haul. We have a lot of work to do. We need to stabilize these programs, make sure that the interventions are there, that they are evidence-based, and that they also weather the storms. Just for instance, with the COVID pandemic, it was one of our major concerns is how do we ensure that these large health programs that are saving people's lives at a very large scale are actually not collapsing in the in such an emergency type of situation. So we need stable and well-functioning health systems, we need nimble and evidence-based interventions, and we need well-trained and, may I say, enthusiastic health workers in order to make this work. So coming back to the district clinical specialist team. So this is the initial team that was employed in the Tshwane district. And you can see the Tshwane district is here in the Gauteng province. It includes Pretoria as the capital city. But it's a very large metropolitan area which this team is now looking after in terms of improving maternal and child health outcomes. If we think about the health needs of children in our district, so there's certainly the need for acute care for acutely ill children. There's also a really big need for neonatal care. And then for childcare, we unfortunately still have children that have these overlapping risk factors of malnutrition, social risks, HIV and HIV exposure, and TB. And it is in this environment where we need to work and find ways to make sure that children have the best possible outcomes. This means we need to screen them for these conditions, and then we need to ensure that they access care, and if they are in need of chronic health interventions, that they actually can remain in care. So in terms of neonatal deaths, I've shown you how naggingly stagnant the neonatal deaths have been. They are a significant proportion of our under 5 mortality. The main causes are low birth weight, birth asphyxia, and infections. And just to give you a little bit of perspective, so a district like Tshwane, so the one that I work in, we have around about 50,000 deliveries each year. We have about 1,000 stillbirths each year and around 650 neonatal deaths per year. So we are not talking about small numbers here. We're still having a lot of newborns and that die unnecessarily, and we need to work towards reducing these avoidable deaths. So in terms of focus areas, I wanted to highlight one particular topic here, just as an example, and this fits very nicely with the fact that it is World Breastfeeding Week this week. I wanted to just give some inputs about formula feeding and the impacts that this is having on child health in our country. So you would think there's a little baby and baby is hungry, baby needs milk, and if we can get milk to baby, then everything is good. The problem is that not all milk is equal, and we know that formula milk, in comparison to breast milk, is suboptimal, because formula feeding is associated with poor outcomes in children, with malnutrition, with deaths and morbidity from diarrhea and from pneumonia. So milk, it does not equal milk. On the other hand, we have pharmaceutical companies and milk companies who obviously are manufacturing formula feeding, and they're doing this also because they want to make money. They do this with very clever marketing strategies, and the issue that they are really also very much aware of is that they need to normalize bottle feeding or formula feeding. If people in the communities think that bottle milk is just as good as breast milk, then it is half the battle won for them. The other thing that one really needs to remember is the fact that weaning of a baby and starting a baby on formula milk is in many ways a one-way street. Once a mother has weaned her baby off breast milk, she is now reliant on the formula milk. So she will continue to buy the milk from the manufacturers. And it is really very difficult for her to go back and actually restart breastfeeding once she's weaned the baby. In our context, the HIV epidemic has had a major additional impact on the infant feeding in our country. So like many things, there are very enthusiasts of everything around in the communities. There is fake news around. So this infant feeding debate is mostly not a black and white type of debate. There's a huge spectrum of people and their opinion. There are, for instance, the big advocates for formula milk, saying it gives women freedom, to choose what they want to do, and all kinds of arguments for formula milk. There are obviously also on the other end of the spectrum great breastfeeding enthusiasts. And the point is that the majority of women actually are somewhere on this sliding scale. They just somehow want to make life work, and they want to be able to feed their babies and ensure that their babies remain well-fed and healthy. So we need to put the woman-infant pair at the center of what we do. Pregnancy and childbirth are life-changing events for women. And discussions and choices about infant feeding can change over time, but we also do need to be able to communicate with women and their families the importance of breast milk and the choices that they are making in this regard. Remembering this one-way street, once a woman has weaned off breast milk, it really is difficult for her to relactate. So we need to help the woman at each step of the road so that she can actually maintain the breastfeeding. We need to empower women to breastfeed within the social context that they are in. Breastfeeding is not a medical condition, it's a normal part of life, but it has a major effect on the morbidity and mortality of children. We need to address the barriers to breastfeeding. Some of them are within the health system, getting off to a good start and helping women with all those practical breastfeeding issues. But there are also many things that are actually part of the society that we need to address. Social standing of women, the need for support, and the woman's ability to balance many different, often conflicting demands. it is something where the whole society is being asked to assist. And in sick and small infants, this becomes even more challenging. So if we have sick and small newborns within hospital settings, this is a high-risk group of children, of neonates, and we need to implement in-hospital interventions, and we need to work on the continuum of care so that this actually is something, a journey that the mother can embark on and receives our support. We need to be having a zero separation of mother and infant policy. We also need to implement breast milk only policies in neonatal units. And one would think that this is a no-brainer, but this is not without difficulties. And often the dividends are not immediately visible. There are many crucial components to actually having something like a breast milk only policy in a neonatal unit. You need to have policies and guidelines in place. You need to have dedicated, knowledgeable and enthusiastic staff. You need to involve the management. You need to have larger mother facilities so that the mother can actually stay at the hospital. You need rooming in hospital beds where mothers and babies can sleep next to each other. Human milk banking for sick babies and sick mothers where breastfeeding is actually initially a hurdle which needs to be overcome. Kangaroo mother care is a crucial component of this, and then early discharge with good follow-up. And this is for the pediatric component. For instance, I've brought this for you as an example. These are many of the things that we are working on as a district clinical specialist team, really supporting the district hospitals and the regional hospital in our district to be able to put all of these components in place. We work with the staff to empower them, to make sure that they are empowered both on a knowledge level, but also that they are enthusiastic and that they feel supported in the system. We do lots of training and we have job aids. This one is, for instance, in neonatal care, because obviously health workers need to also know what they do, and because this also gives them the ability to with confidence, care for the patients that are under their care. And it doesn't help we have very fancy neonatal units and there's no patient follow-up in place. So early discharge is only possible if we have structured follow-up, especially for this high-risk group of infants. You need a multidisciplinary team for such a follow-up, and the continuum of care is absolutely crucial. So breastfeeding support within the South African health system, there are components that are hospital-based, there are components that are clinic-based, and then there are community components to this. And as part of the primary healthcare re-engineering, the district clinical specialist team really works on assisting to bridge these divides, together with the ward-based outreach teams who then have a footprint within the community itself. So really it's the role of bridge builders to ensure that the continuum of care actually can happen. And then the other thing that really we need to think around with these health programs is that they are not functioning in isolation. So for instance, we know breastfeeding is best, but well, what about this HIV transmission? We also know that HIV was one of the major causes of childhood mortality in our country. So how do we balance these risks? So initially, we try to balance these risks by just providing formula milk to women who were HIV infected. And this is where initially in our PMTCT program, they were provided 6 months of free formula milk. But in 2010, after a lot of research done on the African context, the WHO actually changed their guidelines with a focus of HIV-free survival, and with another update in 2016, really harmonizing the breastfeeding duration for HIV-infected and HIV-uninfected women to the 2 years, the same recommendation for all women, except that for women who are HIV-infected, this is within the context of antiretrovirals and viral load suppression. So this is evidence-based interventions that from the WHO, which we as a country have also adopted. Because we have learned our lessons around HIV and breastfeeding. We initially focused on HIV transmission, then we shifted our focus to HIV-free survival. We have learned through the research that antiretrovirals to either mother or infant makes breastfeeding actually a safe option. It's not a second best option, it is a safe option. And we have moved to a public health approach for infant feeding in the HIV context. And through this example, this is what I wanted to share with you, to say all of these shifts don't happen by accident. They happen through good research, but then also through actioning of this, through the guidelines and policies to ensure that we have then health workers who can actually implement these. And knowing the interactions between these health programs and the multifactorial impacts on childhood outcomes. So for instance, at primary healthcare level, we also monitor childhood growth because of these overlapping risk factors that we are aware of. We also know that wasting, so malnutrition, correlates with childhood mortality. So really, this is a no-brainer. We need to make sure that children grow well. We need to ensure that they remain HIV negative. We need to, we need to do a few of these basic things really well, and that means our childhood mortality then reduces. So in summary, I have tried to provide you a picture of the context where the DCSTs work. And this context is the backdrop of high disease burden in South Africa. We need to ensure equitable access, quality healthcare, and this has to be there for all citizens, for the rich and the poor. However, our health system had and still has an equal distribution of resources, a very strong divide between private and public sectors, strong geographical divisions, also urban and rural. Historically had a hospice-centric and a curative approach with strong emphasis on acute care. And the vast majority of the specialists in public sector are hospital-based, and often this results in them being isolated from the primary healthcare structures. So again, the role of the DCSTs is really to be bridge builders, to be trainers, to be motivators, and but also at the same time do monitoring and evaluation and risk management. So in terms of the provision of the healthcare, and the role of the DCST is to assist in providing patient-centered, high-quality care, work in terms of providing clinical governance, training and mentoring, monitoring and evaluation, risk management, teamwork and collaborations, and care coordination. You can see that this is not the role that we usually think of if we think of a specialist pediatrician, like I am, for instance. But if these components are missing, then we can have we struggle as a country to actually impact our maternal and child mortality. So this is also required for the future planning of our health system, and I'm specifically referring here to the universal health coverage. We need to build these roles at district level into the universal health coverage that we are building for us for the future in our country. So I want to thank you for your attention, and I want to end off just to inspire us again with a quote from Nelson Mandela, which is, "Our children are the rock on which our future will be built, our greatest asset as a nation. They will be our leaders of our country, the creators of our national wealth, those who care for and protect our people." And let us live by these words. I thank you for your attention.
I'd like to welcome back our speakers to the platform. So, Uta, if you can turn on your screen, Dr. Berman, if you can come on board as well, and I don't know what happened to Dr. Pistorius. There we go, Dr. Pistorius, if you can join us as well, and my co-chair, Dr. van der Merwe. There's been some questions coming through on the chats. What I'll do is I'll start off with those questions, and perhaps as we go through some of those questions, I don't know if there's the option for people to ask their questions directly. So we'll just hear from the IT team. But let me start with Dr. Berman. Dr. Berman, the first questions that have come through are really around WhatsApp. And the questions is WhatsApp at all not safe? And is an alternative solution the Vula application? Can you perhaps start off by commenting on that? Dr. Berman, you're still on mute.
You must just unmute yourself.
Sorry about that. Sorry, classic mistake. The WhatsApp has just recently been named by the Health Professions Council as being unacceptable. That was in the telemedicine booklet, the second iteration of the booklet that was developed in 2010. They redeveloped the initial booklet, released it in 2010. 2010 in December 2021. It was booklet 10, and unfortunately there were quite a number of areas where they had to rewrite. They've just rewritten it again, and once again they have clearly indicated that WhatsApp falls into social media, and as such that the doctor could come into possession of a lot of information which he, under other circumstances, would not be privy to. And as such, WhatsApp is seen as unacceptable by the Health Professions Council. And it's clearly defined now in booklet 10, the second revised copy. So the first revised copy, just to clarify, was released in December 2021. And in February 2022, they released the second revised version of that same booklet, and again clearly indicated that WhatsApp is one of the social media platforms, and including things like Instagram and TikTok, etc. They've grouped them all together and said this is not an acceptable medium. Now, I saw in some of the other subsequent questions whether Vula can be used. Now, Vula we've actually raised directly with the folks that have put Vula together, and I believe that there should be a meeting coming up in the next week or two that is going to be facilitated between ourselves and Vula to find out a little bit more about Vula and whether they've approached HPCSA, because Vula has not been mentioned as unacceptable by the HPCSA and is not really seen as a social media as far as booklet 10 is concerned. So currently, the answer to the third question which had come up is, what does Dr. X do if there's an incoming request on a WhatsApp? And the response really would be, unfortunately, I can't respond on WhatsApp. You would go back to the patient and say, would you either contact me or send me an email? And then your response is on email. And if it's on telephone, well, then you obviously need to make transcripts. And that's a whole section all on its own. That's a talk all on its own, which is telehealth. So I think I should have probably answered 3 or 4 of those questions. There were quite a couple of duplicate questions. But the last one came up as far as mentally disturbed clients and psychotic patients was concerned. Now, that's a little bit of a difficult one. Mentally disturbed is a kind of a very broad category, and providing that the patient is of sound mind and body and hasn't actually been certified, they may be eccentric, they may be mentally disturbed, but if they've been sectioned, that's a completely different matter whatsoever. Whatever the patient's mental status, the POPIA Act still indicates that the data has got to be kept carefully. The patient has got to consent. Now, if the patient is psychotic, then clearly the patient would need to have a curator. And that curator would be a curator ad persona who would come in with the patient. And this is, the curator would basically be working for the patient's better good. The curator that they talk about. There's others, curator bonuses, which deal with the property and their finances, and curators ad litem, which are the ones that actually they deal with litigation in the courts. But here, this would really be a persona, a curator ad persona, and that individual would then give the consent that the patient may give data, etc., etc. But it borders on more understanding of the Mental Health Act, and it's not really part of the POPIA Act or the PIA Act. But the rights that are that are inferred are the same. In other words, that patient is entitled to full protection in terms of protection and promotion of information, protection of information and promotion of information.
Thanks, Dr. Berman, for that.
Yeah. Sorry, can I just follow up on that? So, so Dr. Berman, just tell me if I understand you correctly. So, should one actually refrain from any communication with patients via WhatsApp?
Yes.
Okay.
Yes, it is a problem, and it was more of a grey area when POPI came out than when the telehealth or telemedicine booklet 10 came out, which was in the 2021 December, and then revised in 2022. But they specifically mentioned, amongst a whole string, they mentioned WhatsApp. And so it doesn't appear that we can use WhatsApp. When a patient contacts you on WhatsApp, the answer that we believe is correct is to go back to that patient and say, thank you, I've received your message. Would you please just rather contact me directly or send me an email, and I'm actually going to delete this particular passage.
And can I, sorry, Ziad, if you allow me back to Vula, because Vula is actually very popular now and used a lot to refer patients.
Yes, correct.
So there's actually a lot of patient information that's being shared on Vula. So at the moment we're still okay to use that.
Yes, because it hasn't been named, and I'm really hoping to meet the fellows within the next week or two to find out a little bit more as to have they approached the HPCSA, and do they have a legal opinion. But at the moment we're not saying don't use Vula. Also, Vula doesn't have a commercial feel as much as WhatsApp does. I don't believe that Vula is actually owned by Google or by, I think that WhatsApp is owned by Google. And also the encryption is a bit of a problem on WhatsApp. It is encrypted end to end, but the problem is that where the encryption is decrypted, you don't know if the area or the territory is inside South Africa or outside of South Africa. And I'll talk more about that tomorrow. But if they are saving the information on servers outside of South Africa, then the POPIA Act says that those servers have got to be compliant with the General Data Protection Act of the UK or the HIPAA of the USA. And we would need to get confirmation that that was also correct. In that wherever our data is going to be stored, if it's offshore, that whoever and whatever is storing that data has got to be compliant with international regulations. So yeah, the storage of offshore data is rather grey at the moment, but our regulator is insisting that wherever we store it outside of the country, we've got to know that the data and the way that it's stored is compliant with either the GDPR or the HIPAA regulations.
Thank you, Ziad. Over to you.
Thanks, Dr. Berman, for that. Let's give you a bit of a break there. Maybe you can catch your breath. And let's move on to one of the other speakers. So there's a question for Uta. Uta, the question from Virginia is, have the district management teams been able to retain staff, and how do they relate to the district managers? And if I could just add one more point to that is, the reporting systems, I believe that one of the biggest challenges for the district teams were that the reporting channels were from the primary healthcare level was not to the district team, which made life very difficult for the district specialists.
Yes, thank you very much. Those are absolutely excellent questions and very practical for us. Remember, we were a new team that came into the district health services, and it was new for us, and it was also new for the district. The districts were used to having like family physicians, but they weren't used to having a pediatrician and an obstetrician around. And yeah, so the other thing to remember is that there's a maternal and child health program at the district level as well. So they are not a clinical team like we are. They are really looking after the health program activities. But there's still obviously a lot of overlap between what we do. So in terms of, so if you think about the question about were districts able to retain the staff, so well, actually we need to start whether they're able to attract staff to these teams, and the answer is only partly, and that's because of the short you know, there are just not enough health workers in South Africa to go around. So not all districts were initially able to actually attract full teams, and especially the rural districts were really struggling in that regard. Some of the provinces have subsequently also decided to actually dismantle their DCSTs, and this is, for instance, the Northern Cape. They were arguing that they were struggling to attract specialists to hospitals. So they were saying, how can you have a specialist obstetrician and pediatrician, for instance, as an example, in the district, but not in the regional hospital? So there have been some practical difficulties with that. In the province where I'm now from, Gauteng's got 5 teams in each district. They're not all complete teams, but they pretty full, fully manned. Our team has been, we've had a complete team from the start, except for the anaesthetist that almost all teams have had difficulties attracting anaesthetist to the team. But we've had a family physician, an obstetrician, a pediatrician, a primary healthcare nurse, a midwife, and a pediatric nurse all along, and we have been able to refill our posts as people have gone on retirement, for instance. Yeah, the reporting line. So the team is as such usually has a team lead, which provinces and districts do different. We sort of in our team we've elected our own team leader. And that's really a coordinating role that this person is, and we've mostly had our family physician actually play that role, which is, I think, ideal, because that's the role for family physicians, is really to coordinate services and then also they are. So for us that was the natural choice. And we report directly to the district manager, which in our district has worked very well. But yeah, some of the districts have had difficulties in terms of the reporting line, and certainly these are important questions because you can only work well when these line management issues are sorted out, for instance. And then yes, we are a support team. We keep on saying that to staff. I mean, we've got like 72 clinics and 5 district hospitals and a regional hospital to look after, with 10 midwife obstetric units. So it's a big place, and lots of clinic and hospital visits. We are there to support the staff. We are not their line managers, and that is good and bad at the same time. But it's usually good because when we go and do support visits, we're not there to punish them in any way or something. We keep on saying we're a clinical team. We're there to train and mentor and help them to implement good quality care at the clinics and the hospitals. Yeah, but sometimes obviously if there are things that need to be reported, then we do need to take it up with the line managers of the actual health workers who are involved there. Yeah, but I think I'm going to pause there.
Thanks very much, Ute, for that. There's still questions coming through in the chat. If you can just have a look at it, and Dr. Behrman, if you can also look at it. But let me bring in Dr. Pistorius to answer a question. And I think we've just lost him. Okay, so while we're waiting for
Dr. Pistorius had to climb out because he was having bad connectivity due to load shedding.
Okay. No, that's fine. So I'll move on back to you, Dr. Berman. Maybe Haynes, do you want to ask a few questions from the chats then? You're on mute, Haynes.
Sorry. There are two questions on the length that records should be kept by practitioners, and just to sort of come on to that, we've had, and obviously it happens quite a lot, we've had a colleague that passed away recently, and his wife had the problem, what would she, what is her obligation with regards to all the records that her husband kept, and in the same vein, if a practitioner would retire, what should happen with those records? How should it be kept, and for how long?
Sure. Okay. So look, there's been a lot of initial misunderstanding, but this rests on two pillars. It rests on one, which is, what does the Health Professions Council say? And then two, what does POPI say? So let's look at the HPCSA first. And the HPCSA expects us to keep records for at least 6 years. So after the last date of inactivity, you're expected to be able to produce your cogent records for 6 years thereafter. And kind of a mantra that we say to our doctors is, no records, no defense. Now, we never won't defend. It makes defense very difficult if the dog ate your records, or if there was a flood, etc., and it was never reported, or the house burnt down and you haven't got a forensic report on that. So the HPCSA says you've got to have 6 years worth of the records from today. If I consult somebody for the next 6 years, that somebody's got to keep my records for 6 years. At the end of the 6th year, the HPC says if you haven't got it for 6 years and 1 day, they would find it difficult to find you wanting. So that's the first one. The second one is, what does POPI say? So POPI is a little bit different. POPI says you can't keep the records for longer than 6 years. So HPC says you need to keep them for 6 years. POPI says after 6 years, you can't have them anymore because you've now got information which you no longer need. Now, there are exceptions. And on the folders, which, and I'll talk about destruction in a moment, but on a folder which you would then deem you may get rid of, you can withhold that folder from destruction by indicating that this particular folder I need to keep for longer than 6 years. And for an example, a plastics implant. We've seen those horrendous businesses happening years after a plastic implant. An orthopedic implant. Some folks who have had complicated forms of surgery where they might years later need someone to actually look back to see what has been done and what was anastomosed to what. So there's a good reason to keep that, and then POPI says that's fine. And HPCSA says that's absolutely fine as well. Not a problem. HPC is not saying destroy. POPI is saying destroy after 6 years, unless you have a good reason why you mustn't have them any longer. So it becomes music to the ears of a doctor who is retiring or who's running out of filing space. Because over a couple of weekends, you can, if you are still keeping hard copy records, you can pare your numbers of records right down. Some folks have got records that go back years and years and years. Now, if we look at pediatrics, that's a completely different matter, because pediatrics, you've actually got to keep your records because the child becomes a major at the age of 18. And then from 18 to 21, he or she has got the right to notice something, and prescription would start to run when they achieve the age of 18 until the age of majority, which is 21. So the pediatricians, completely different reasoning. But this is the general rule, is after 6 years, destroy unless you have a real good reason why you should keep them. And no one's going to challenge you on that. But you can't keep everything, because you would get a challenge if you have an inspector. And the council, HPCSA, says you need it for at least 6 years. So I hope that answers the question broadly. It's a much more complicated question, but I've tried to kind of condense it because I know that we're sitting at 1 minute to go, and there may be other questions.
Yeah, thank you very much, Ziad. Back to you.
Thanks for that, James. I think we've got 5 minutes, so there's still time to take a few
okay.
more questions. So, and they're coming in, so that's great. Let's go over to Uta. Uta, the question is, how can we support and promote breastfeeding in women post-cesarean section, as a lot of women fail to initiate breastfeeding due to the pain during this time?
Yeah, so that's a fantastic question, I must say, and it's one of those really difficult areas where one does need to work with the staff. I mean, the one thing really to remember is that the baby.
It went to silence. Sorry.
Okay, it said the host muted me, so anyway, I've unmuted myself.
That's not me.
Yeah, so what's really important to remember is that the baby's latching reflex is really strong in that first hour of life. So we do need to get it right in that post-op area, where the post-cesarean section. One that needs to work with the staff in the theatres and really emphasize the fact that the skin-to-skin contact within the first hour of life is important for all mother-baby pairs, and that includes the post-cesarean section babies. Yeah, so but yes, one does need to. The theatre is often cold, and you know there are other things to consider. The mother may be very ill. Obviously, if the baby is ill, these are the things that complicate this decision in terms of the skin to skin. But the basic principle is each mother-baby pair should have skin to skin contact and initiate breastfeeding in the first hour of life, and they should, except if there's a medical reason why this can't happen. And yeah, so it's a big ask, and it's one that one really needs to work on.
Thanks for that, Uta. If I can come back to you, Dr. Berman, the real difficult question here is, what are the implications if we contravene the act? You're on silent, Dr. Berman.
There we go. Okay, so we've been given the kind of reassurance that the regulator is not out to catch us in the first year or so. They are much more keen to actually engender cooperation, and for us to embrace why POPIA's there and how itself has brought PIA into its kind of folder, which we'll talk about tomorrow. But if there's a gross violation, a gross violation would be, shall we say, deliberately selling secrets of my medical condition onto the dark web, and getting caught. Maybe not as grave as that, but maybe having left the office open with highly confidential records in it, which every one of us is highly confidential. And the stuff doesn't just get messed up and burned, but resultantly gets into the wrong hands. I lose my position, the company is in disgrace, etc., etc. Then if this is seen as a gross violation, 10 million rand is the fine, and or 10 years in jail. So it is pretty grave. Now, the jail sentences can be anything from 12 months up to 10 years, and there's a whole range in between. But I think what they're trying to say is you better take this seriously. You really do need to work with the idea that POPI is not there to make our lives more difficult. In fact, once you've gone through your records, your filing cabinet is going to be a hell of a lot easier. And on destruction, you've got companies all around the country who will actually come and weigh your stuff, give you certificates of destruction for a specific weight. And you would then be able to produce the fact that on such and such a day, you destroyed X number of records. You might or might not need to have an itemized list of what was in there. I would always suggest that you do. So the folder on the Berman family was in this this bundle of destruction. So that's really my plea on this series of 2 lectures I've put together for you guys is I don't want to frighten anybody. It's a question of rather cooperating along the POPI lines and along the PIA lines. But if there's flagrant violation, yes, there are definitely some very, very sharp teeth at the very end of it all. Yeah.
Thanks so much, Dr. Berman. I think we've really come to the end. Heinz, do you want to say the final closing remarks?
Yeah, thank you very much, Ziad. Yeah, we have come to the end of the session. I think a fantastic session. Thank you very much to the speakers. And when we started, I was a little bit concerned that we might not get any questions. In the end, there was not enough time to answer all the questions. So thank you to the speakers. Thank you for everyone who attended and for your questions. And from my side, I hope and trust that the rest of the meeting will be just as successful. So from my side, colleagues, thank you and goodbye.
So thanks from my side also, colleagues. And I think we go on to the next session, which is the networking session, and then to the keynote speaker at 5 o'clock.
Hi, good afternoon. Can you hear me, everyone?
I can hear you. Hi.
Hi, thank you. Thank you, Prof. Renee,
I'm just
can
wondering
we...
whether it's better with or without my speakers.
Okay. Yeah, its sound is very clear and loud.
Okay, so I don't need my speakers.
No, thank you, Prof. We are going to start our session 3. I am the moderator for this session. I am Akhtar Hussain, Board of Director of South African Medical Association, and also the Chairperson of Public Sector Advocacy Forum of SAMA. I'm a specialist family physician working in Durban with the UKZN. It's a great pleasure and honor to introduce our keynote speaker, Professor Glenda Gray, about how COVID-19 research helped Republic of South Africa's response. Now, Professor Gray's CV is very extensive, but I will try to summarize, which is not possible. Let's start her neonatal history. Prof was born in Boksburg, Gauteng, and her qualification include medical degree, MBCS from Wits Medical School. She has FC Pediatrics, she's a pediatrician. She have DSc, LLD, doctorate in law from Rhodes University, and the PhD around the world from many countries. Professor Gray is a National Research Foundation's A1 rated scientist. So she's not only the scientist for South Africa, she is recognized by the world. She is the first female president and chief executive officer of South African Medical Research Council. Professor Gray is a co-founder of the internationally recognized perinatal HIV research unit in Seattle, Her global profile include a role as a co-principal investigator of HIV vaccine trial network. Professor Gray is also chairperson of the board of the Global Alliance for Chronic Disease and a member of the Institutes of Medicine of National Academies of United States of America. Prof. Gray has received South Africa's highest honor, the Order of the Mapapungoabe, for the pioneer work and research in PMTCT work. And we follow your work, Prof, that PMTCT, when incidence maternal and child was 43%, and especially the highest number was in KZN. And after this PMTCT research is almost road to zero. We hardly see mother and child transmission in a newborn baby unless somebody escaped from the crack. Professor Gray is also received the prestigious award that is Nelson Mandela Health and Human Rights Award. Professor Gray selected as one of the Times Magazine's 100 most influential people in the world, and as well 50 most powerful women by the Forbes. During our COVID-19, Prof. Gray was appointed to the South African Government Medical Advisory Committee member. She has published more than 300 scientific articles, most prestigious A-rated journal in the world. Prof. Gray is almost single-handedly secured 500,000 doses of Johnson & Johnson, that is JJ vaccine. And it was the only hope for health workers those days. And Prof, that JJ gave us the boosting to go and work frontline doctor. She is a fearless advocate for doing what is right above all else. Please welcome Professor Glenda Gray. We all like to hear from you. Floor is you, Prof.
Thank you so much. Thank you very, very much for your introduction, and thank you very much for asking me to present today. And it's really unfair because I have to compete with the Springboks and New Zealand as they start their rugby game right now. So I do apologize. Hopefully you've got the screen up, or you can also watch on silence. So thank you very much for allowing me to talk today. I'm going to share my, can you see my screen? Are you able to see my screen?
We can see it, thank you.
Oh, excellent. Okay, thank you very much. So I'm going to talk about how COVID-19 research helped South Africa. And this is to look back at COVID, and also to look, as the SAMA conference says, beyond the pandemic, looking forward. And so I'm going to start off by saying what the MRC did, and also give you some idea about what the scientists in South Africa did. But very soon, when we heard that the pandemic was starting, we started to think about what should our response be. And myself, together with a team of scientists, looked at a research strategy. And so in March 2020, we were able to ring fence around just under 20 million rand from our baseline funds and from the DSI SHIP funds to repurpose for COVID research. We were then able to get additional money between March 20 to March 2021, and this was from the Alma Foundation, and this was to help the NHLS with their work on diagnostics and reagent and equipment. And we were also able to get money from Solidarity Fund to also support search testing. We worked with TIA to fund COVID diagnostics, because at that stage there was very little diagnostics in the country. And we also were able to repurpose money from our baseline for therapeutics and other funding. Between April 2021 to March 2022, we were able to secure money to do the Sasonke rollout. as well as doing additional work with vaccine studies, which I'll go to, and then work on wastewater and other immunology funding. So that was just our response and the money that we were able to garner to help support the research strategy in South Africa. In addition to making sure we had enough money, we also wanted to make sure that we had an ethical way of dealing with some of the key issues we had to grapple with when it came to science. And so we established a bioethics advisory board that gave us some advice about trial design, issues around who should or who shouldn't be treated, certain vaccine trials, and also the issues of placebo. We also decided to collaborate internationally to accelerate vaccine research because we knew that as a country we could never afford to fully fund vaccine research by ourselves. So we worked together with a whole lot of other entities, including the NIH. We also had as I've mentioned before, a set of research principles that were agreed upon, and we were able to fund these with international peer review. We worked very hard with advocacy and community structures as well as with the regulators, in particular SAHPRA. And the nice thing about South Africa is that we have multiple research ethics committees. And so having all of these committees reviewing the protocols, we were more likely to have a good consensus about the clinical trials that we were embarking on. What is the first lesson that we learned and the lesson for the future? And that was the importance of surveillance. So I'm going to talk a little bit about the variants of concern, looking at CT thresholds, the importance of excess deaths, wastewater surveillance, and why hospital surveillance is also important. And so, as you know, we started off with our first surge when we went into hard lockdown in March. This was followed by the emergence of a beta variant of concern that sparked the second wave in our country. And then we had our third wave, which was fueled by Delta. And then in December last year, we had our next surge, which was the Omicron BA1, BA2. And more recently, we've had the Omicron BA4, BA5. And so all these surges have been identified because we invested in COVID-19 surveillance. And so we spent about 75 million to date looking at surveillance and epidemiology. And I think one of the important things is the HIRAX Biosciences, which was a software that enabled us to detect the SARS-CoV-2 variant. We funded this program initially for HIV and then for TB, and we were able to rapidly use this platform for SARS-CoV-2 identification of variants of concern. And just to say that this HIRAX Biosciences that we use, the software, is not only used in South Africa, but has been used in 29 other countries, including 11 other African countries, and was funded, as I mentioned before, for HIV initially. And then we set up the Network for Genomic Surveillance for South Africa, which was run by Tulio and in collaboration with the NHLS and with funding from both the Department of Science and Innovation and MRC. We were able to monitor the emergence and spread of new SARS-CoV-2 to inform rapid response. We worked with the international science community, tracing the movements of SARS-CoV-2 across the countries, and understanding was important to see how these new variants would impact on vaccine efficacy. And we've been able to advance South African science with already 44 publications and peer prints to date for this surveillance. It just gives you an idea of the surveillance that happens in our country, in all the provinces. And so there's a surveillance set up in all the provinces, and each week samples come to reference laboratories where genomic analysis is being done. And this just shows you what we've been able to do. And these come out on the website on the NICD on a weekly basis, and you can see the various variants and how they emerged. Looking at where we are now, if you can see in April, we had a combination of BA4, BA2, and BA5, and you can see how in May this changed to mostly 65% BA4, and then in June the emergence of BA5 and the less BA1, BA2, and mostly BA4, BA5 from June onwards. What we learned about surveillance was open access was critical, and the South African scientists were able to feed into GISAID and to upload the genomic sequences so that these could be shared and could inform both assessments on vaccine efficacy and development of new vaccines. Looking at the SARS-CoV-2 CT analysis, this is important analysis that is done on a weekly basis by Leslie Scott and her team. And this just looks at viral load in samples coming in. So it's community-based viral load. And when it's an inverse cycle, so when you see these peaks, that's low viral load, and as the curves go down, in fact, the viral loads go up, and so you can predict the next surge. And these areas, as they on the downswing, so from about February to May 22, you see the viral load going up, and then the viral load going up after May, and then the viral load coming down to 4.2, which indicates a mild spike, and this may be fueled by the emergence of new variants in South Africa. So it's very important to always watch out and see what the viral load is, because this helps us predict the next surge or the next wave, depending on if it's localized or not. Excess deaths is also a very important surveillance. MRC has been doing excess deaths for many years now, and because not all SARS-CoV-2 infections are diagnosed, a very good proxy about the deaths that are occurring in the country will come from excess deaths. And yeah, or you can see our peaks of excess deaths always mimicked the surges that were happening, and so we can say that about 80% of all the excess deaths, more than 80% of all the excess deaths that happened during these surges were probably attributed to SARS-CoV-2. And all in all, we've had more than 300,000 deaths, which is much more than the recorded deaths from SARS-CoV-2, indicating that South Africa suffered heavily from SARS-CoV-2 and probably had about the fifth highest deaths from COVID at a global level. And this just shows you some modeling that the MRC was involved in, and you can see by looking at these data is that again confirms that South Africa was one of the hardest hit countries in the world when it comes to SARS-CoV-2. The important issue around the hospital surveillance, this work is done by the DATCOV hospital surveillance, and this is the work of Wasila Jassat. And it's very important for us to track the relationship between cases, hospital admissions, and deaths. And this is what we saw with Omicron, was a decoupling of deaths and hospitalizations from admissions, and a nice way to track how severe new variants of concern are by looking at the decoupling and seeing what's going on. So this was very reassuring when this data came out, because we were very worried when Omicron broke out in December, but we're very reassured to see the decoupling that was occurring. Importance of the DATCOV database is also critical to understand, how severe this wave will be. Is what the NICD does, takes the first 4 weeks of all the waves, and they compare hospital admissions with death. And yeah, you can see that this is reassuring, because as you go into the fourth wave, you can see that the death rates and the hospital admissions were much less than in previous waves. Important from the DATCOV database, we can also see what the risk factors were for mortality. So if we look here, you can see, if we use the Western Cape as a reference, one of the hardest hit provinces was the Eastern Cape, that had almost a doubling of risk factor, a risk for dying as compared to the Western Cape. And also looking at the public and the private sector, showing that if you compare to the private sector, the public sector, you had 1.5 more risk of dying as compared to if you were in the private sector. Looking at age groups like the rest of the world, high risk factors as the older you get, above 60, 20 times, and above 80, more than 35 times. Males more likely had a greater risk factor of dying than women. And there again, you can see as compared to white, Black Africans, coloreds, Indians, and people that weren't classified were more likely to die, probably indicating poor access to healthcare in the various provinces. If you look at risk factors, again, hypertension, diabetes, chronic cardiac disease, and malignancy, as well as tuberculosis and HIV impacted your risk of dying from COVID. Looking at Western Cape, you can see this is based on all public sector patients in the Western Cape. You can see that again, an age increased risk of dying the older you were, and with comorbidities as well as TB and HIV. This just shows you hospitalizations due to COVID, and showed you the age range by wave, the age distribution for children, and particularly in Omicron, because there was a concern that more children were being admitted. And this just shows you the value of good data that are coming out of our hospitals to be able to track this ahead of many of the other surges that were happening across the world. This is an interesting paper because it shows the cost and the hospitalization and mortality in South Africa. And so if you look at the cost, the median cost per patient, 24,000 Rand for children less than 80, and the older you get, 83,000 Rand for the cost of a hospitalized person over 65. Men cost more than women, 60,000 as compared to 50,000. And interestingly, if you compare the cost per province, you can see the Western Cape was 47,000 and the Eastern Cape was 48,000, despite the fact that mortality rate was higher in the Eastern Cape, and Gauteng had the highest cost of around 54,000 per hospitalization. So nice to see the distribution of costs that are happening. KwaZulu-Natal also around 50,000 Rand per hospitalization. I spoke a little bit about wastewater surveillance. So very early on in the epidemic, in around May 2020, both the MRC and the NICD established wastewater surveillance. Wastewater is an important tool to try and predict clusters or outbreaks. And normally you see a surge in wastewater about 7 to 10 days before you see an outbreak. You're also able to do genomic analysis to pick up SARS variants of concern. And we're also using this wastewater surveillance to now look at monkeypox and measles for the future. This just shows you some of the data, the importance of wastewater in tracking variants of concern in South Africa. So a very useful tool, which we need to take through into the future. This just shows us our expansion. We were able to expand to a lot of historically disadvantaged institutions and set up wastewater laboratories in their institutions. Lesson 2 was investments in diagnostics, and this just highlights the investments we did. I mentioned before Leslie Scott, where she was able to do continuous quality monitoring of CT values, which helped us identify and monitor outbreaks of SARS-CoV-2, and also helped us to inform the performance evaluation of diagnostics coming in. And so we're able to get this information initially bi-weekly, and we're able to disseminate this information both in South Africa and out. Bhavesh Khanna, very early on, cultured SARS-CoV-2, and he used this to help diagnostics, and this was deployed to NHLS and also to 26 other countries. And this helped us to develop scale PCR-based diagnostics, and was very important, and we should be very grateful to the work that he did in his laboratory. We've also been able to support the development of 2 locally manufactured COVID diagnostics that have recently been approved by SAHPRA, So just showing you the investment, being able to do this locally was very important. And trying to fast track these diagnostics to market, and the importance of making sure you can identify a commercial partner, to do regular project monitoring, make sure it's always collaborative. And then also it's very important to work with NHLS and the WITS Reference Lab and SAPRA. Important to have political backing and lots of publicity in this. And so very exciting that we were able to bring diagnostics to the market. We were also, as I mentioned before, able to fund surge testing in programs. So when the public and private laboratories were unable to keep up with the pace, we had developed capacity in academic labs to support diagnostic testing. And this was quite critical because we've been able to move this on to do the wastewater surveillance as well as being part of the genomic surveillance as well. So I also, the next lesson was investment in vaccines and therapeutics. We committed money by working with global partners in the Solidarity trial, as well as funded the first COVID vaccine study, the CHADOC study, led by Shabir Mardi in the beginning. We also were able to be part of an international collaborative effort, and we were able to evaluate the single-dose J&J vaccine, which enabled us to be able to roll this out long before any EUA vaccines, long before this was an EUA vaccine. And this just shows you looking at severe disease and critical disease, you can see that as compared to placebo, the single-dose J&J worked very nicely. This enabled us to roll out Sasonki and deliver the vaccines, as you mentioned, to just under 500,000 healthcare workers in South Africa. As you know, we started this vaccine trial on the 17th of February, and then we were able to boost our healthcare workers with a second dose of this, where about around just under 240,000 healthcare workers got boosted. And then after that, they were able to receive the Pfizer heterologous boost from about February this year. This shows you in South Africa, we were able to provide real-time data that the vaccine worked in both with the Beta and the Delta variant, and provided reassuring evidence to the healthcare workers that were working in the country that there was still an impact of the single-dose vaccine. We were able also to collaborate with Discovery, and were able to compare both the two-dose adeno with the Pfizer. And here you can see adeno and Pfizer, 0 to 13 days, 14 to 27 days, and then every month, and looking at hospital admission and high care or ICU, and showed that the adeno and the Pfizer were working very well together. Looking at the Omicron period, people were very worried about the Omicron vaccine and Omicron variant, and whether the Pfizer vaccine was working. We were at a global level. We had data before anyone else in the world, and we're able to also again reassure that the two-dose Pfizer vaccine was working based on data coming out of South Africa. We've been able to, as I've mentioned before, do a boost of the Sasonki with both the J&J and the Pfizer, and we'll be evaluating the Pfizer vaccine effectiveness on top of the 2 doses of adeno. We've also been able to look at the role of full dose and half dose Pfizer or J&J on the original Sasonki study, and we've been able to now also we're also doing a study with Moderna, boosting people who got 2 doses of adeno 26 with Moderna, and also similarly looking at other vaccines and new variants that are coming that are new vaccines which contain variants that are coming into the country. We also learned the importance of investing in basic science. We were able to very early on follow up a group of healthcare workers in South Africa and follow them through the waves and follow them through their vaccination process. And this was led by Ntobeko Ntuzi, together with Jonathan Blackburn and Wendy Burgers. And we were able to see the impact of previous infections and the impact of vaccinations on immune responses. So this is a critical piece of work that's given us a lot of information about hybrid immunity. With Penny Moore, we were able to support the establishment and validation of a serological and neutralization assay, which helped us understand whether there were any, what impact a new variant had on neutralization and escape. And these were very important work that we did. Wendy Burgers from Cape Town also did a T-cell immunity for all our vaccine studies, and Alex Segal was able to culture the live virus and evaluate the viral escape, as well as share his live virus assay with many people and many scientists at a global level. This just shows you some data coming out of the Wendy Burgers lab, and showed you various healthcare workers who received adeno 26 and looking at boosting and looking at spike protein. So just to show you the kind of work that we were able to do and generate information for the world, basically based on the adeno 26 J&J and as well as the Pfizer. The next lesson that we learned was the importance of investing in vaccine manufacturing, particularly local vaccine manufacturing. And so South Africa was able to compete to become an mRNA hub, to set up, to receive mRNA technology transfer, to scale it up at BioVac, and then to evaluate this for both mRNA, for both COVID and future vaccines. So it'll use the mRNA as a platform to do this. And we've been able to work with many people. We've already designed the first phase of this study, and we hope to start the first in human trials using the Afrigen mRNA early next year. So very exciting. Once we know that this works, we'll be able to transfer this technology for other vaccines like TB and HIV. So it's a very exciting space to be working on, and proudly South African in this area. This just shows you how we use everything that we garner in South Africa to help us understand and do the work. So the genomics is very important. So our genomic surveillance is critical. It's important for us to understand the immunology, how to do the vaccine construction, and the lipid carriers, which Wits has been involved in, the enzyme production at Stellenbosch University, process development at UCT, the pilot production at Afrigen, and the preclinical at PUDAC and Northwest University, and then clinical work done by the clinician scientists in South Africa. So a very exciting process that will help us become very competitive globally in the future. I've also learned, we've also learned the importance of investing in capacity development. When we decided that we wanted to do biomanufacturing, we realized that we had very few people that we needed to scale up. And so we worked with the Patrick Soon-Shiong Foundation that have given us 100 million rand to basically do a capacity development to build up a skilled workforce for the biomanufacturing sector. And this program we've developed in conjunction with various academic institutions and other organizations. And so Sub-Saharan Africa does need to build a vaccine manufacturing capability. We need to be able to support tech transfer from all the major companies. And we've estimated we need more than 600 skilled scientists, postdocs, PhDs, masters in science, and both technician and school leaving people, and working together with a whole lot of people to try and realize this. I want to acknowledge some great scientists who've done great work in South Africa, and that's Shabir Mahdi, who started the first COVID vaccine trial and has been critical thought leader in the pandemic, as well as Tulio, who was on the forefront of identifying the new variants of concern and establishing the genomic surveillance. So they are two great heroes that deserve a special mention. What are the COVID-19 lessons that we've learned? We've learned that that COVID has demonstrated a need for and a massive and global collaborative scientific effort. And we need to do this with rapid dissemination and sharing of our results and our data. South African researchers have been great and have pivoted their existing expertise towards COVID from TB. We've been able to leverage a decade of investment in projects and platforms The MRC and the Department of Science and Innovation have reallocated and raised substantial funding for COVID R&D, and we also have seen new funders that have emerged that we didn't tap into before. COVID has taught us the urgent need to establish capacity for local manufacturing of PPE and other medical devices, diagnostics and vaccines. And this has accelerated efforts on all these fronts with support from the local government and other funders. It also taught us the need for collaboration, cooperation, agility, and rapid response. And we have achieved this on an unprecedented scale in South Africa. And these lessons and capacity and new ways of working must be harnessed and perpetuated so we can really gain from all we've learned and move forward for the future. So when we look forward and we think about what a future preparedness framework should look like, I've mentioned the importance of surveillance, and this is critical, whether it's excess deaths, genomic surveillance, and hospital surveillance. They're all very important. We also need independent and transparent ways of investigating origins into a new pandemic or a new pathogen. What we've seen in South Africa is that the health system is not resilient. And in the future, we need a health system that is resilient, and we need to make sure that we protect our healthcare worker with proper protection and support and vaccination and treatment. And so I want to just acknowledge all the healthcare workers that faced all these waves and were the backbone of the care in our country. We also need to make sure that anything we do to mitigate the spread of a pathogen doesn't impede our economic activities and doesn't impede schooling, and should always prevent corruption. We need to invest, as I've mentioned before, in vaccine and therapeutics, and we do need to establish this with and looking at the no-fault compensation. But all in all, we also have to make sure that we protect human well-being and make sure that there is mental health support during these processes, because we've seen a lot of post-traumatic stress disorder and mental health issues emerging. I want to say that, to finalize, as we've seen with SARS-CoV-2, science knows no country because knowledge belongs to humanity and is a torch that will illuminate the world. And I do believe during SARS-CoV-2, science was the torch that illuminated the world and gave us hope. So on that, I'm going to just acknowledge all the healthcare workers again. This is just a picture of healthcare workers waiting to receive their jab, and just acknowledge them and thank them for contributing and taking part of Sisonke and for being the backbone of this pandemic. Thank you very much. I'm going to end there, and I'm happy to take questions.
Thank you very much, Prof. And excellent presentation and lot of information. Prof, we will go to Q&A question answer, but before that, can I ask few questions?
Sure.
In Japan, more than 100 to 200,000 COVID-19 cases daily, despite actively vaccination program. Then the second question is, will South Africa see another wave of COVID-19 and when? And last night I read US declare monkeypox outbreak, national health emergency. And the last question is, SAPRA media released one death post-vaccine of J&J vaccine, and that is due to the Guillain-Barré syndrome. Will this help to the anti-vacciner? Thank you, Prof.
Thank you very much for those questions. And so the question you ask about is the relationship between vaccination and breakthrough infections. And so despite vaccination, people in Japan and in South Africa have had breakthrough infections. So the original vaccines were designed to protect against the ancestral or Wuhan strain and induced a very broad neutralizing antibodies against them. But as the variants have emerged, we've seen huge escape from neutralization, which means we see breakthrough infections. The good news is that even though we do get breakthrough infections, the vaccines have helped to prevent severe disease and death. And this is obviously mediated through T cell, CD4 and CD8 T helper cell responses, and some of the neutralizing antibodies. So what we do need is probably vaccines that have the variants in them. So the FDA have indicated that they are looking for bivalent vaccines that contain the Wuhan strain together with new variants, and they've identified BA4 and BA5 as the variants that they need in the vaccines. These vaccines will be available. Moderna and Pfizer are making them, and they'll be available from the end of the year, from about October, November in the US. We'll see when that gets moved on to us. So I do think that we will see a waning of vaccine efficacy as new variants of concern emerge. And we do need regular boosting. So even though we can't prevent breakthrough infections, we can try and prevent severe disease and death. New vaccine platforms like the Novavax may be important boosters and help with preventing breakthrough infections. So we haven't been good at preventing infections, even though we've been good at protecting people against death and hospitalization. You ask whether South Africa will get will have another surge. So as long as there's transmission, so we're in a kind of, I guess, almost an endemic state at the moment. So there is ongoing transmission, but it isn't at a high level. Will we get another wave? We might see more waves as new variants of concern emerge. And we know that people who shed the virus chronically are more likely to have viral evolution and have a new variant that emerges. We've been watching. There's been a little bit of grumbling, some activity in South Africa in the last few weeks. And so we're watching to see what's happening as we go. We're in winter, so ventilation, people are in closed doors, ventilation isn't good, people are crowded, so we may see some upticks, but hopefully the hybrid immunity that we have and the vaccine coverage that we have will make sure that we still see the decoupling of cases with death and hospitalization. Monkeypox is an important important virus that's emerging. We've seen at a global level, people raising concern. This is spread, this is not a respiratory virus, it's spread by intimate contact and mostly in men who have sex with men. And so at a global level, a lot of countries are vaccinating groups that may be at risk of getting monkeypox, and maybe we might see that happening in South Africa. In terms of the SAPRA media release this week around the person who died of Guillain-Barré after receiving an A26 vaccine. Guillain-Barré syndrome has been reported in a lot of vaccines, and also in the J&J vaccine. It occurred, I think, after 10 million vaccinations, so it's about a 1 in 10 million incidents. We did see Guillain-Barré in Sisonke. We did have some cases. They were diagnosed. If they're diagnosed early and managed properly, then they're not likely to be fatal. And this person, it sounds like from what I've heard from people, is that this person got Guillain-Barré syndrome and died of a nosocomial infection and sepsis. So very sad. So I think what we have to always look out for is that make sure that any vaccine-related adverse event is quickly picked up and managed so that it doesn't result in any fatality. And so yes, I think that the important thing is that it is a rare event, and unfortunately that this had a bad outcome. So I'll stop there. I think I've answered all the questions that you asked me. They got harder and harder.
Thank you so much.
They got harder and harder.
Yeah, no, that's good. Prof, on Q&A,
there is one question. The decoupling of Omicron in December, what is the reason that happened? is there a difference between the natural versus induced via vaccine immunity in terms of quality and effectiveness?
I'm on mute. That's a very important question, and this decoupling that we saw between cases and hospitalization deaths has been attributed to this hybrid immunity. So high previous exposure plus vaccination does alter your immune response. And so what we did see is that South Africa benefited much more than any other country to this hybrid immunity. And we didn't see such a, we saw that in the US, they still went on to still have terrible hospitalizations and deaths, even with Omicron, indicating that there were a lot more people in the US who were naive to SARS-CoV-2, and not having this hybrid immunity did impact on their outcomes. And so I do think that we have benefited from a hybrid immunity, and that vaccination with SARS-CoV-2 or SARS-CoV-2 with vaccination has broadened our immune response. And I still think it's important for us to continue to get vaccinated. We shouldn't rely on our past, because we do see waning. We see waning of both natural immunity and vaccine-induced immunity. So a regular boosting until we get a variant vaccine or a vaccine that prevents infection is probably the way to go. And then there's a second question about Nhlapho.
Yeah.
Okay. Yes, that's very important. So as we look at the future and we look at pandemic preparedness, what is the role of an entity like Nhlapho? So NICD was critical in our response to COVID, NICD and NHLS. And Nhlapho has been, it has gone through the, it is an act, and Treasury needs to put a budget to Nhlapho. And I guess what needs to happen is between NHLS and NICD and the MRC, we need to work with this new entity, Nhlapho, to make sure that what we do is synergistic and we don't want to duplicate work. And so I think we all have to sit down and make sure that resources are very scarce, and to make sure that we do the country the best service and not duplicate efforts. I think Nhlapho is going to be important, but we also need to make sure that NHLS and NICD, as well as MRC, work with the new entity to make sure it works.
Thank you, Prof. I don't see any other question on Q&A.
There is one last question about how long does T cell. So obviously the T cell immunity at both there'll be memory T cell responses and current current T cell immunity. So looking at the data, it appears that if I talk about the J&J work, we saw good T cell, we saw good immunity out to 8 months. And then obviously, as your CD4, CD8 T cell responses go down, you also get memory T cells that will be activated once you get exposed to the pathogen again. And hopefully those memories T cell responses will then assist you when you get exposed again. So you will get waning, but hopefully there will be enough memory to help with it, to prevent, to help you with your immune response.
Yeah, thank you, Prof. We still got 15 minutes. If any other burning question for Prof.
Okay, if there are no other questions, Prof, on behalf of South African Medical Association,
for your commitment for this conference. We know you just arrived from international trip. Oh, sorry, is muted.
Hello, can you hear me?
Yeah, we can hear you.
Yeah. So, Prof, what I was saying, we know you just arrived from international trip this morning. I'm sure you're very tired, but your commitment and your presentation is taught us a lot today. On behalf of South African Medical Association, we really like to thank you so much. As usual, you always come and give us an excellent presentation in SAMA. So I would like your closing remark for doctors, students, medical students, and for community. What should we do further? Thank you, Prof.
Yes, thank you. So, I think we also have to acknowledge the important work that medical associations and bodies like yours, like SAMA, does do. I think SAMA was critical in the negotiations with care, with ethics, and with supporting the response. And so, I think one of my non-research question would be, but another lesson learned is the importance of bodies such as SAMA to support, junior doctors, doctors, specialists, and the health system. It's critical. So I just want to acknowledge all the work that the doctors did, and particularly the frontline people that had to face wave after wave. So it's deeply grateful for serving the country so sterlingly.
Thank you very much, Prof. So we can close this session.
Thank you.
Thank you.